Dear doctors, we'll be going live in 1 minute.
ये मेरे पीछे देख कितना कुछ है.
Dear doctors, we are going for live.
I'll start.
Dear doctors, we are live.
Hello, everyone. I welcome you all to this two-day webcon hosted by Association of Obstetric Anesthesia, India. Devi Saraswati is hailed as the goddess of knowledge. So let us start this academic feast by invoking the blessings from Ma Saraswati. I request now that President of the Society, Dr. Sunil Pandya, address the gathering of delegates who have gathered in large numbers all across the globe to attend today's webcon. Over to Dr. Sunil Pandya for an address.
Good morning, good afternoon. Good day of Association of Obstetric Anesthesiologists. It's my privilege and I'm delighted to welcome you all for this two-day 13th annual conference which is being held on the virtual Omnicuris web platform. This conference was supposed to be held last September at Kolhapur, Maharashtra, but as we all know, the COVID 19 global pandemic has put the entire world into topsy turvy, and we are here on a new platform, virtual platform. Hopefully, we should meet you all physically very soon. Association of Obstetric Anesthesiologists India over the years have grown tremendously, not only in numbers but also in terms of gathering or the attendance that we see in our annual meet. The first conference of AOA was held at Chennai in 2008, and since then we have come a long way. Today, at the 13th annual WebCon, even for this virtual conference, we have close to 2,000 registrations. This is despite 3 to 4 parallel major anesthesia fraternity meetings happening simultaneously. So probably I would say the success of AOA is because of its rich scientific content and importantly the participation by the international and national faculty of repute. The international faculty of repute who has been a tremendous support throughout from the first conference has been Dr. Bhavani Shankar Kodali, Dr. Arvind Palaniswamy, and also OSAO members who have been with us right from the time of inception. In addition to the annual meetings of AOA, we as association also conduct several training programs and one-day small training programs, CMAs, in the outreach areas, in the semi-urban, the rural areas of country, with the basic premise that we standardize the practice of obstetric anesthesia across the country, thus making anesthesia for childbirth very safe in our country. And importantly, few of our obstetric anesthesia colleagues have taken a lead in managing critical care even in public hospitals. And thus, AOA has immensely contributed in reducing maternal mortality in our country over the years, even though we are still at around 50 to 60 maternal mortality rate if you look at the average MMR across the country. Critical care in obstetrics was one of the niche area that AOA identified, and we conducted the first national course of obstetric critical care in 2008 at Hyderabad. And since then, we have standardized the obstetric critical care course, and it has become a regular feature now. And we have been doing this course annually or even biannually across the country and even internationally. We have been invited to conduct this course even in countries like Oman, Philippines, and few other countries. Furthermore, AOA also has collaborated with WFSA Safe Obstetric Anesthesia Training Program that was started in 2018. And AOA with WFSA, we have conducted 4 such courses in Telangana successfully, and we wish to enter and penetrate the rural and the semi-urban areas across the country. All this has been possible because of the brainstorming that happens at the AOA core task force committee. And the Journal of Obstetric Anesthesia and Critical Care is our niche area, another niche area which Dr. Anjantrika is the chief editor, and he has been publishing since 2011. Before I conclude today's talk, welcome note, I again welcome you all for this gathering, two-day gathering, and I thank you in advance for being a part of this virtual conference. And this webcon is possible only because of the effort of Young Ladies Brigade of AOA. I should name a few of them: Dr. Kajal Jain, who is at the helm of affairs, Dr. Anju Grewal, Dr. Aruna Parmeshwarin, Dr. Shilpa Kasodekar, who have been brainstorming the papers. Almost close to 86 papers were presented during this conference. And of course, Dr. Angelina, Dr. Rezi, and the youngest of all, Dr. Sunanda, who have made this virtual conference. I'm sure it will be a successful conference with all the support. And also, I thank the Omnia Curis platform for giving us this opportunity for this platform to meet you all across. Thank you very much, Dr. Kajal, and I invite Dr. Sunanda Gupta to give her remarks.
Thank you very much, President Sir. Thank you very much for appreciating the team behind. So now, may I invite our revered founder, president of the society, Dr. Sunanda Gupta, to come and address the gathering, give a clinical pearls or pearls of wisdom, and declare this webcon open. Ma'am, may we have you, please? Ma'am, kindly unmute yourself.
Hello. Very good morning and humble namaste to all the different time zones of our speakers who have joined in from across the globe and from within the country, the postgraduate trainees and fellows, and all the AOA colleagues and all the home delegates. It's indeed a proud privilege to have the best brains of obstetric anesthesia across the globe on the same platform. And we are really lucky that they will be addressing us for 2 consecutive days. Um, we have been really fortunate that we called Ruth, or we called Dr. Kodali or Stephen Gatt or YK Chan. They all accepted to address our conference in spite of the different time zones. And this association, which was founded way back in 2008 with a small band of dedicated obstetric anesthesiologists, has come a long way, and now we are close to 1,000, and that really makes our heart swell with pride. Um, as we said that we had started this program 2 days earlier, and there have been many papers which have been shortlisted, and now tomorrow they are going to come online and compete for the best paper award. And before I wind up, there are some pearls of wisdom which I want to dedicate to my postgraduate trainees and fellows who have joined in large numbers here. The practical wisdom lies in how best you choose to manage your cases within the operation theaters, how you face the challenges and the critical scenarios. So, the practical knowledge that you gain while managing a collapsing, hemorrhaging parturient forces you to unobtrusively introspect, reflect, and learn from your seniors and your colleagues and your teachers. Now, remember, applied sciences and research are going to widen the boundaries of your knowledge, but they are really not going to equip you with the ability to manage these cases. So it's very important that experiential insights, which the best brains of world obstetric anesthesiologists is going to provide you in these 2 days, are going to be really helpful to you. And as you all know, obstetric anesthesia is a very dynamic branch, and you need to keep yourself updated with the new consensus guidelines which come in, the new equipments, the new drugs, the new drug doses. You need to be well aware about it. And so it is important that you keep yourself updated so that you can provide safe obstetric anesthesia to our patients. So our endeavor today is that we provide you this platform for all the delegates with international faculty as well as our home faculty, and a salute to all the Corona warriors. I know all the postgraduates have been working day and night, and they are totally mentally and physically exhausted. So we have a lecture coming all the way from Sydney, which tells you how not to burn yourself out for the obstetric anesthesiologists. And we need to have experiential insights from our foreign faculty, which is going to teach you how best to strategically manage PAS, preeclampsia, a difficult obstetric airway. And you also need to look into how differently and with a different perspective you should be looking at oxygen, which YK Chan is going to deliver. And so in the end, I wish you all a very happy new year and hope that with the collective efforts, we'll be able to ensure and implement maternal safety for the mother as well as the child. Thank you so much.
For giving us this inaugural address and declaring the webcon open. So we will start today's session, and as a moderator, I have this pleasant duty to inform certain housekeeping rules, just to keep in logistics and some administrative issues which can happen through this 2 days webcon. The first one is that there will be a lot of question and answers which will come to the mind of all the attendees. I request you all to follow this link to send us the questions. We'll be looking at your questions all through these 2 days very diligently, and then we'll process them and send them across to the speakers. However, if your questions remain unanswered, we will take them up again at the end of the session if there are some time constraints in between. So you will not be able to ask the questions live on this platform because you are on viewing this program through OmniCurious platform, and we are on a Zoom platform. So I request you all not to get impatient. Please use the link and send us the questions. And along with this, another thing is that if you need to contact us, we have this number which you can dial in for any internet connectivity issues, or if you have logged out inadvertently and you would like to now come back again. We have info@at omnicurious.com, always there to help you out during this 2 days program. So now I invite you all to enrich yourself from the live streaming from experts. Having said that, I invite our first speaker, Dr. Y.K. Chan, who is the honorary professor in the Department of Anesthesiology, University of Malaya, Kuala Lumpur. Dr. Chan has immense interest in high-risk obstetric patients with their accompanying complex needs. She's a subject expert and lends medical legal advice in Malaysian jurisdiction. Ma'am Chan is a teacher by nature. She actively participates in activities conducted by WFSA Education and Obstetric Anesthesia Committees. And I must tell you that Dr. Chan is our regular AOA faculty. She is attending all our conferences and lending a lot of knowledge-based enhancement in these gatherings. So, ma'am, may I advise you, may I request you to please speak on 2 lives, the anatomy and physiology of death. Over to Dr. Y.K. Chan.
Good afternoon, ladies and gentlemen. I am so honored to have been invited by the AOA India to be a speaker in the webinar. And I'm going to share some thoughts on the 2 lives that matter to us very much as obstetric anesthesiologists. And I'm going to focus on the anatomy and physiology of death. I have no conflict of interest to declare in this presentation. I'm going to share with you the situation with regards to my mom's death. My mom died at the age of 80 following a fall. She was quite a beauty when she was young, but of course she lost it to wrinkles by the time she died. And my sister and I were very fortunate to have been at her bedside when she transitioned from life to death. And we were, in fact, more comforted when our cousin visited and made a remark that says she was more beautiful in death. And the physiologist in me could not help but try to explain to all those who were gathered how the sodium that was outside the cell has actually moved in because the sodium-potassium pump was no longer functioning in her death, and water has moved in as well, and the cells had got swollen and eased her wrinkles and created the beautiful person that she once was. When I look at these 2 deaths that happened in the department, however, I would not describe them as beautiful. In fact, if anything, they were very ugly because they affected 2 young ladies who were still in the prime of their life. The first was a single lady who had an intrauterine death at 32 weeks, and she stayed away for 2 weeks. And when she arrived, she actually was having roaring sepsis and she collapsed and could not be resuscitated. The other lady was also a young lady, a foreigner, who went into labor pain when her husband was not around. And because she was not able to get into the hospital on time, she tried to deliver her own baby. And of course, by the time she arrived in the hospital with the dead baby, she was in an exsanguinated state. Every year, globally, especially in the sub-Saharan African place, many mothers die under very similar situation to the two deaths that I have actually described. Equally, globally as well, about 2.6 million babies die at stillbirth before they even had a chance to experience life on Earth. And as an obstetric anesthesiologist, I would like you to actually look at using your knowledge, especially the physiological concepts that we are going to share with you, to look at how we can reduce the morbidity as well as mortality in these two lives. So, what is it that really keeps us alive? Do we live to eat, or do we eat to live? Actually, we eat in order to bring the energy sources into our system so as to stay alive. And it is the energy that is the basis of life. And that energy is in the form of ATP. All energy actually comes from the sun. Plants are able to capture the energy from the sun in the process of photosynthesis and produce energy sources which we ingest. And together with oxygen that is brought to the cells and ultimately to the mitochondria, the energy is converted to carbon dioxide, water, as well as ATP. And for all the energy sources in us, the conversion is very efficiently done in the presence of oxygen, but in the absence, you can see the inefficient state of conversion. There are two types of oxygen users. The oxygen conformers would belong to animals like the hibernators, where if energy sources are limited, the demand comes down in together with the supply. However, humans are not oxygen conformers. We are oxygen regulators, where if the supply does come down, the demand does come down as well. But after a while, there is a gap between the demand and supply, resulting in energy failure. And this energy failure is the precursor to morbidity as well as damage and ultimately death in us. This concept of energy failure has also crept into the obstetric literature, as you can see here. This article by Murray, where they were talking about energy metabolism. I shall be referring to this article later on again in the presentation. We definitely need energy to stay alive, but we do have an organ, the liver, which is a good storage organ for this energy source. However, as I said, we do need oxygen as well, but there's no storage organ for oxygen. So we do need a constant supply, and that supply has to be breathed in through a patent airway by the process of breathing and then brought into the circulation, pumped around by the heart, and oxygen is then combined with the hemoglobin and brought to the cells and ultimately into the mitochondria. So if actually one follows the pathway of oxygen to the tissues, one can actually see that if one has failure of oxygen delivery, it could be due to a failed airway, failed breathing, failed circulation, even what I would consider failed hemoglobin or inadequate hemoglobin, or failed microcirculation in the tissue itself. So If one looks at the causes of maternal death in the global arena, we can see that the big killers of our obstetric patients are hemorrhage, hypertensive disease, and sepsis. Well, hemorrhage would be equivalent to failed hemoglobin, and hypertensive disease and sepsis would be equivalent to failed microcirculation, where oxygen delivery is impaired. As anesthesiologists, most of us cannot influence care as the patient comes into the hospital setting. We are always at the more definitive area of care. But if we recognize that a patient is coming in, we can actually put in strategies to improve this care, especially when they arrive at the definitive area. And all of this must be done in a timely manner because energy and oxygen delivery are time-sensitive processes. Dr. Singh recognized the usefulness of alerting and creating the environment for more remarkable care in the obstetric population as well when he modified the early warning systems that's generally used for the general population for obstetric use. And he has done that in 2012, modified it for obstetric use so that when we recognize life threats in this population of patients, using this, we will be able to recognize the threat early and put care into the correct perspective for the patient. Similarly, as a community of providers, we have also moved away from general anesthesia to regional anesthesia in order to improve care for the obstetric population. In fact, in the early 80s, anesthesia-related death was the fourth highest ranking killer in maternal death. I do remember those times. But since then, when we moved away from general anesthesia to the use of regional anesthesia for our obstetric population, the case fatality rates secondary to general anesthesia have come down, as you can see over here. Now, this is actually data from the United States. The regional anesthesia cause of death is low, but there seems to be a suggestion of the rate going up as well. And before 1990, as you can see in the black columns, yes, the death rate or the case fatality rate were high for both mother as well as the fetus. But post-1990, with the conversion to greater use of regional anesthesia, all this has come down. The case fatality rate for anesthetic-related death has actually come down. So if you actually look at the situation, it was due to failed airway in many circumstances, as well as failed breathing or respiration. However, if you look at more current data, you will find that while we have removed failed airway as well as failed ventilation as a cause of maternal death, using regional anesthesia, we have converted many of these deaths to be due to failed cardiovascular system. Here you have neuroaxial cardiac arrest as well as high neuroaxial block as being responsible for maternal deaths post-1990. As obstetric anesthesiologists as well, we have great capacity to also look at sustaining life of the fetus in utero. We must actually understand that the pathway of oxygen to the fetal tissue is actually much longer compared to the pathway of oxygen delivery to the maternal tissue, because from the mother's side, oxygen still has to move into the placenta through the umbilical cord into the cardiovascular system of the fetus before it can be distributed to the fetal tissue. And it is this longer pathway that is responsible for the greater number of deaths in the fetus every year globally. Every year, we have about 500,000 mothers dying as a result of their pregnancy, but we have something like 3 million fetuses dying as stillbirths. And if you look at category 1 cesarean section and the factors responsible for this category of cesarean section, you will find that energy failure is more likely to hit the fetus. These are all the reasons here. More likely to hit the fetus more than the mom. And similarly over here, if you look at the resuscitation requirement of the fetus of those born under level 1 cesarean section, you will find that most of them have energy failure and need some form of resuscitation. In fact, the life of the fetus is actually very, very tedious. The oxygen saturation in the fetus, once it's gone through the tissues of the mother, through the placenta and into the fetus itself, the saturation is only about 70%. So you could almost say that all fetuses in utero experience hypoxia. And we do know that compensatory mechanisms exist to allow the fetus to cope with this hypoxia. At birth, the hemoglobin of the newborn is 16 gram %, and that is one of the compensatory mechanisms. And we also know that the fetus has got fetal hemoglobin with higher affinity for oxygen. We understand that double Bohr effect also exists to increase the diffusion gradient of oxygen from the parturient to the fetus. And if you reflect upon it, the fetal circulation is actually redesigned to bring better oxygen delivery to the brain. Over the next 2 slides, I will try to explain item 3 as well as 4. The oxygen dissociation curve of the fetus is to the left of the maternal oxygen dissociation curve. At the placenta, when the fetus unloads its carbon dioxide onto the mother, the oxygen dissociation curve moves to the left. The maternal oxygen dissociation curve upon receipt of the carbon dioxide now moves to the right. So there is now a greater gradient for the diffusion of oxygen from the parturient to the fetus. We do know in the adult situation that when there is hypoxia, blood is actually redistributed away from the non-essential organs to the essential organs in the heart as well as the brain. And if you reflect upon the hypoxic state of the fetus, you will recognize that oxygenated blood comes into the right atrium, goes to the left atrium, and then into the left ventricle, and is preferentially distributed to the heart as well as to the brain. So because of that favored blood flow with oxygen to the brain, in fact, by the time we come to term, the brain is the densest organ in the whole body. And it can potentially explain why 95% of us are born capillate. In the more hypoxic situation of high altitude parturence, Murray actually found that the compensatory mechanism was such that the oxygen delivery was compensated to deliver more oxygen through the uterine vessel. And however, the demand of oxygen and energy, in fact, the demand for energy is reduced in those fetuses in the high altitude compared to those in the normal sea level. And as you can see here as well, those born in the high altitude, because of that energy failure present in them, their birth weight is actually lower compared to those in the low altitude or sea level babies. Most of the time, I actually like to liken the oxygen delivery to the term fetus as to the events of oxygen delivery to the boys that were caught in Chiang Rai in the caves in 2018, especially at the end of the 2 weeks entrapment. And as well as the water level in the whole place rising to prevent adequate oxygen from arriving at where the group was. When they were finally rescued at the end of 2 weeks, note that they were given air bottle of oxygen and full face mask. This is what one should normally do in patients or in babies who are delivered at the end of a level 1 urgency kind of situation. However, many a times I actually get very flustered when the pediatrician attending to these babies make a stand and refuse to administer oxygen. Or worse still, they may sometimes place untrained providers to look at resuscitating these patients as well. And I have also in my medical legal work seen how the tragedy unfolds, especially because of inadequate oxygen being administered or poor care being provided for these babies, and them resulting in a lifelong period of damage. Now that we've migrated to the use of regional anesthesia for our cesarean section, and of course, increasingly use regional anesthesia for our epidurals and pain relief for our parturients, it is very important to make sure that oxygen delivery to the fetus is our main prime concern as well. In fact, since the 1990s, we recognize the importance of avoiding aortic compression by making sure the uterus does not compress the aorta. Of course, it is you can actually perform left uterine displacement, or you can put a wedge to ensure that the aorta is not compressed and that the fetal circulation or the flow of blood and oxygen to the fetus is not impeded. And in all critically ill pregnant patients, it is important to be mindful of that and to ensure patient is placed in full left lateral position and administered oxygen. And of course, in a cardiac arrest situation, it is important to recognize the usefulness of left uterine displacement. This particular study by Stacy actually also looks at a very interesting relation to energy failure. What happened was, in a retrospective study, she was looking at mothers with stillbirth and asking them their sleep position. And she found that those with stillbirths were sleeping in a non-left lateral position in the 1 month, 1 week, as well as 1 day period before the stillbirth occurred. And this was and in fact, this warranted an editorial on the subject. And we should probably be mindful of this and encourage all our pregnant patients to sleep on their left. Oxygen and energy delivery is a time-sensitive event. And we do realize that this way of classifying the urgency of cesarean section, which has been in place since 2010, is very closely related and does emphasize that particular aspect of the time-sensitive nature of energy delivery. And it is once it is linked to energy failure, and providers are taught the concept of energy failure and see the concerns as part of energy failure, they will actually rise to the occasion of providing correct care for our patients. Energy failure is more likely to occur in the emergency situation, and unfortunately, the emergency situation outnumber elective situation in the 24-hour period in most areas. If you compare the outcome of fetuses or newborns born under emergency situation compared to elective, you will see that they are all significantly present and asphyxia resuscitation almost occurring threefold. And poorer ABGAR scores are also significantly lower in the emergency situation. So what I have here in the t-shirt of this man who was a stranger, but I managed to capture in one of my visits to Argentina, tells or encapsulates what I would really like to share with all of you. When you do see a life threat where energy failure is present, you must drop everything and work on the problem of your patient. So in summary, death is an easily measured endpoint, it's the tip of the iceberg, but the hypoxic damage, which is the submerged part of the iceberg, is just as bad, if not worse. And oxygen and energy delivery is the basis of life-focused care. And oxygen is an enabler of greater ATP production. Oxygen delivery to the fetus involves a longer pathway, and we must be mindful of that. Timely, appropriate care for both mother and fetus would ensure their survival. So as obstetric anesthesiologists, it is important for us to remember the two lives matter to us, and we must do something right for them. It is the beginning of a new year. May I take this opportunity to wish everyone Happy New Year. And with that, I would like to thank you for your attention.
Very much, Dr. Chan. That was a very, it has opened sort of a new area of interest for many of our attendees. I have few questions also lined up for you. So can we start with some questions which have come up? I believe it has, the energy failure in newborn has stimulated a lot of interest. And the first question which we have received says, what do you mean by physiological death? What is physiological death?
Well, actually, a lot of us, whenever we describe a death, we are actually looking at categorizing the death as occurring when the heart as well as the respiratory control is lost. Of course, for those intensive care patients, it would be when the brain control or the brainstem control is also lost. These are actually all physiological causes of death, if you understand. And it is not like the ICD classification of death, which is actually an economic way of looking at death, you know, where all the countries of the world, or somehow over the years, the cause of death has been classified in terms of economic needs instead of the cause of death as a failed airway, a failed process of breathing, the circulation has failed. So oxygen and energy cannot move to the tissues. So that's my concept of a physiological cause of death. Whereas previously, if a person dies, let's say from a myocardial infarct, why a myocardial infarct is actually not really a physiological cause of death, but an economic kind of cause of death in the international classification of death, is because then the government says, okay, I must actually put aside funds to help all the deaths that has come through because of myocardial infarct. So their health budget will be tilted in that kind of direction, or malaria as a cause of death, so that again money will go towards the malaria patients. Whereas physiological cause of death is something that we have not really put a lot of effort in. But because we don't have a way of classifying it this way, a lot of times we cannot get at errors, medical errors that occurs as a result of a failed airway, for example. Maybe the endotracheal tube has come out and the patient is paralyzed. That would be a failed airway as a cause of death. So I hope I've explained what exactly I mean by that.
I also think so, because it is quite a tricky question. And then there's another one which says that you say that fetal circulation is redesigned to combat intrauterine hypoxia to some extent. So should we ensure oxygenation during cesarean section under regional?
Well, the thing is, previously I used to give all mothers oxygen. Then I realized, well, their saturation is already high. So the more important thing is to make sure that they have a left lateral tilt, especially with regional, so that the cardiovascular system, there's no cable compression, so that venous return is adequate, cardiac output is adequate, and then the fetus will get enough oxygen as well as energy. So it is, I do not any longer administer oxygen to all my patients, except when the oxygen saturation comes down in the mother, then I will administer oxygen.
Thank you. And then there's one more which asks, does sleep position also affect birth weight?
Sorry, the sleep position.
Also affect birth weight?
Well, it'd be a very interesting 9-month study, if not 9 months, at least 6 months. In the last 6 months, probably all of us should try to do a study, but I'm not very sure whether it is feasible to do that study. Although in my department, at one stage with a trainee, we were trying to look at making sure that the mother was in the left tilt as opposed to the control group, which we didn't bother, to find out whether the blood gas was any different. But obviously, with just a 24-hour left lateral and left tilt position, you can't really tell the difference in the blood gas.
Okay. So there's another one which says that, do you measure serum pyruvate levels rather than lactates?
No, I don't. We don't have access to that levels.
Okay. Well, Dr. Chen, it was a very interesting session, and we all have a different view to what actually happens during left uterine displacement. What happens when we are trying to resuscitate the fetus in utero? Actually, we are all trying to tackle energy failure in these newborns. So that's a very interesting talk. And if you stay on with us, and if there are any questions at the end of the session, maybe we will address those. For the time being, we'll move on to the next one. Thank you for being with us. Thank you so much.
Thank you very much.
So we move on, and I have the pleasure to introduce Dr. Karunakaran Ramaswamy from Sidra, Qatar. He is an attending physician at Sidra, Qatar. He's a very keen researcher, a renowned international speaker. He's actively involved in training, workflows, simulations, and safety drills. Karunakaran is very well known to us as KK. He comes to all our obstetric sessions, and he is actively participating with us for these safety drills. And he is going to tell us today on teamwork assessment tools in obstetric emergencies. It's a very important topic because this is what actually makes a maternal team effective and safe: leadership and teamwork. Over to you, KK.
Good afternoon, everyone. Thank you for the invite. I have no conflicts to declare. So my talk is teamwork assessment tools in OB emergencies. And this has got three very important words. I think we need to spend some time to understand what these actually mean. So one is team, second is assessment tools, and third is OB emergency. So let us start with understanding what a team means, and do we really know what a team means? So this is Project Aristotle. Google wanted to find out what are the components of a really good team, what makes a good team and what makes a team click. And they started this project in 2012, and they had to continue for 6 years to understand, and they interviewed about 180 teams to find out what makes a team work. But what was fascinating was, of all the things, Google did not know what a team actually means. Do we know what a team means? Is it your hierarchical structure? So if you work under a manager, is that your team? If you share an office, is that your team? Is it whom you work with in your OR? Is that your team? What exactly is a team? So Google spent some time actually to define what a team means. And this is the definition they came up with. It's very fascinating definition because we don't view team like this. So team members need one another to get the work done. So they have a very powerful word in between called need. So without them, your work will not be done. So for example, we are in midst of a pandemic. We need PPE. We need safe disposal of PPE. Do you actually know who brings your PPE in? Do you actually know who's taking all the infected PPE away? Have you even taken time to speak to them? So are they not team members? So it's a very, very powerful statement. You need them. Without them, your work will be paralyzed. What did they find after spending so much time interviewing people? I just want you to focus on 1 and 5, and I'll just take some time to describe. So 1 is psychological safety. This was the most important thing for a team to perform well. Whoever you put along with the team, if the team did not feel psychologically safe with each other, if they thought they cannot take risk because someone may say something bad against them, then that team would not succeed, however technically competent that team were. It's just like if you ask any driver on the road, they will say, I'm the best driver. So we always feel that, oh, I'm a very nice person. People can always come and talk to me. And when you go back and actually check, it may not be the case. And there are some videos in the end which probably will show you that it may not be the case. So psychological safety is absolutely crucial for your team to work well. And the last is impact. Do they actually know what impact or the work they do, what impact it makes on the final outcome? If they don't do their work properly, do they actually know what effect it's going to have on patient safety or the organization? I think these two are very important. And let me just share with you a very good anecdote which happened to me recently. I was walking past our hospital garden. I saw two gardeners. One was digging a hole. The other person would come and fill it up straight away. One would dig the hole. The other person would come and fill it up straight away. I was fascinated. I just went to them and asked, what are you guys up to? So the first one said, my job is to dig the hole, so I'm doing that. The second one said, my job is to fill the hole, I'm doing it. Then the first person said, actually, we have one person in between us whose job is to put a plant in the hole I've dug, but he's off sick, he's not well, but we are really sincere and we are still doing our job without fail. So without understanding, without knowing the impact, these things can happen. And if you think Google is the only one which thinks like that, Apple thinks very similarly, their competitor. So Steve Jobs, when he was actually making the Pixar office, he was telling that every team, they should come to the center. They should be able to meet each other. And he actually suggested all the toilets should be in the center of Pixar office. So whoever it is, they need to come for a break, comfort break. They have to come to the center of the Pixar office. And if you look at the new spaceship campus for Apple, again, you see they prefer people to come to the center. You don't know who we will need, and that is where you meet, and that's where you exchange ideas, and things happen. So big companies or big teams, they think that psychological safety and impact is absolutely crucial. So we will just quickly watch a video So you all probably have a vehicle or a car, and you know how long it takes to change 4 tires. And this team says they can do it in less than 2 seconds, and they challenge they can do it in less than 2 seconds. Let's have a quick look. Isn't that amazing how quickly they can change 4 tires? And we'll watch this in slow motion in a second. But if you just take a step back, this is not very different to what we do in real life. So we have a patient who comes in either to the birthing center or to OR. There is a task, there is a procedure which needs to be done, and we need to ensure the patient goes out safely. So the similar, or it's very, very similar to what we do. It's not very different. And if you just take a step back and think, the last stat C-section you had, or when the patient, how was the transfer from birthing center to operating theater? Was it very smooth like this, or was it chaotic? Okay, forget that. And if you just take even a much smaller things, how was the transfer from the bed to the OR table? It's a very simple procedure, transferring the bed from the bed to the OR table. It happens every day. And how smooth or how complicated or chaotic was that? And we may say, oh, we have a much bigger team. So our obstetric team is very different. We have a patient partner and we have all these people to communicate with. It's more complicated. But if you think from Google's point of view, are these the only people you need in your team, or do you have more people? This is where we are still nowhere near where many other industries are, because the way they are thinking is very different to what we are thinking. I'm going to play the video, which I played earlier in slow motion. I want you to focus on two very important things. One is there is a leader, team leader, who is just overseeing and not doing anything else. But even more important is nobody interferes with each other's work. Nobody interferes with each other's work. Just have a look at the video and see what happens. Just observe, nobody is interfering. Everyone is doing their job. Zero interference from anyone else. And off he goes. Wouldn't world be such a better place if everyone is doing just their job and not interfering in others? But this is something we can learn from other industry and be very, very competent in what we do. And so if you look at very dependable teams, these are the two key things which happen. One is they're technically very, very strong, which is usually not a problem in medicine. They are where they are because they are really good. They have been trained, they've been checked, and their contribution is checked. And second aspect is the non-technical skills. These are the usual 4 domains, and I think we'll spend some time talking about them today. So what I've been trying to talk about is, do we really know what is a team? Do we know everyone who we need to do our work properly? Do we make them psychologically safe? Can they come and tell us if there is something wrong? Can they come and give us some suggestions? Can they come and give us ideas and not feel threatened about it? And do they understand the impact they're having? Just like in a good marriage, so if you look at this tractor, there is no front wheel, but the good wife is making sure the tractor doesn't tip. So you need a good balance of technical skills and non-technical skills. No team is perfect, and a balance of these is what's going to make a team good. So moving on from team to the next step, which is assessment tools. This is a very famous cartoon, apparently told by Einstein, about if you ask the fish to climb tree, it's very likely going to fail. So our team is made of a variety of members, and having the same assessment tool to judge all of them would be an absolute fallacy. It would be wrong to judge people just based on one kind of tool. What do we mean by assessment? When you say an assessment, you're telling that you had a curriculum and you have trained people on which you're going to assess. To the best of my knowledge, there is no formal training. I mean, there is formal training, but it's not part of a curriculum in any anesthesia or any other training. It's just slowly coming in. if somebody does not perform up to the mark in the assessment, is there any remediation? Just like in ACLS, if somebody doesn't perform, you get a remediation. And if they persistently don't perform well, what are you going to do? Are you going to take their license away? What is the consequence? So, for example, pilots have to go through this assessment, and if they don't perform up to the mark persistently, then they can lose their license. So, when we use the word assessment, there are consequences, and we have to be very careful when we use the word assessment. What would be more suitable would be feedback or structured feedback. We are again, there is lack of standardization. Reliability is questionable, especially if you're talking about teams, and validity is for individual teams and not as a team as a whole. And most of the literature is coming from Western world and may not be applicable to other industries. So what are the tools available? So if you look at the tools available, even here, they're looking at individual teams like anesthetists. They have their own surgeons, they have their own scrub practitioners, they have their own. And usually, if you look at these are with these 4 domains. And that's why I was saying, instead of using it as assessment, we should use it as structured feedback. So they look at situation awareness. It's an A4 page. You can print it, and we can use this. It's very user-friendly, and use it for structured feedback. So looking at situation awareness, decision-making, how do you work in a team, and how is the leadership? There is one which has come out, which is looking at the whole team. So it's Oxford Notex 2. There was a Notex 1, and they've added 4 more domains to the ones I just showed you. Even now, if you look, our team concept is surgical, anesthetic, and nursing. We are still not able to take a step back and look at the bigger picture the way other industries are able to look at. Maybe this is something, there is a big gap, and I'm sure there are many professors and many teams here who can work on this and see how we can take this forward. And these are the 4 more domains which are added, which is there in yellow. And again, it's an A4 piece of paper which can be printed and can be used for, I would not say we should use it for assessment, but more for structured feedback. So this is about assessment. So we have talked about team. What does a team mean? We have talked about feedback, structured feedback loops. Third thing which I want to come over is obstetric emergency. So this is the third in the topic. We assume it happens in hospitals, but majority of the obstetric emergencies are happening in the periphery. It could be in primary health centers or villages or wherever. And whatever tools we are going to use, we should be able to implement in periphery. It does not have to be, when we talk about drills, it's always a state-of-the-art simulation center, and how many centers have it? And not every place has it. And we should come up with tools which can be used everywhere. It happens regularly, so we must anticipate, and we must train, and we must be prepared based on local guidelines. What I have in my hospital may not be available in other places. So it should be based on what is locally available. So I'm just showing a video. This happened in Bahrain Grand Prix.
Before the halo was introduced,
I'll just let you listen.
quite a few tests at various angles of a chassis, a dummy chassis that they had with a halo on, just to time how quickly it would be for a driver to get out. And you can see now why Roman would have.
So this is Roman, one of the drivers in F1. He crashed and his car burned, and he was extricated so quickly. And you could see the commentator was saying that they practiced this multiple times. Suppose if there is a fire in your OT today or tomorrow, do we even know where our fire extinguishers are? Do we know what we are going to do? This is something we need to think about, and I'm going to take you through a structured way by which we can do that. So what options do we have to train, and what are they available? So these are some of the options which can be used anywhere. It doesn't have to be state-of-the-art simulation center. We can do it in periphery also. And I'll briefly go through each one of them. First and foremost, very simple thing we can do is what if. So if you're on call, you have time free, you just sit with your team and go through what if a patient comes with PPH. Do we have all the things we need? Who is going to do what task? Do we have all the medications we need, and how we are going to deal with it? If somebody gets anaphylaxis, what are we going to do? Last, what are we going to do? So we can just go through scenarios. It doesn't have to be in one day. Whenever you're free, you sit with your team and discuss how we are going to address this emergency. What this really is bringing everyone, this is called as a mental model, which means it brings all the team members at same kind of mentality or same way of thinking. And it's very powerful. So if you speak to people who win Olympic medals, they picture themselves standing on the podium, singing their national anthem, and it's a picture which runs in their mind again and again. It's a very powerful way of getting things done. Even Rahul Gandhi imagines that he is going to be sitting on Prime Minister's chair. It's a mental model. So, sorry, that's a joke, but it's a mental model. The more you train as what ifs, it's a very simple way of training the team with very minimal resources. Second is, when we talk about simulation, we always think we need a simulation center, we need state-of-the-art simulation. It's not. It's absolutely not necessary. Most of the emergencies are going to happen with your on-call team. So you have a team which is available. You need a way so that you can alter vital signs. You have to make your heart rate go up or blood pressure come down or whatever you would want to do. You need a way to do that. And I'll show you how we can do that. Absolutely crucial to have a way of recording videos. In today's world, even in the most peripheral part, people have mobile phones or handycams. It should be very easy. And this can be played back either on a laptop or a desktop or a television. This is crucial, and I'll go through that in a minute. We talked about training tools earlier, or debriefing, standardized debriefing tool. And it's very important that we have a really positive debrief. And it's a non-threatening and a nice debrief. So what we can do is, it does not need to be state-of-the-art center. It can be very, very simple. So we have a team. How do we record vital signs? How do we change vital signs when there is no live patient? You have lots of apps, both in Android and in Apple. These can be downloaded. At least the Android ones are free of cost. And all you have to do, suppose you want to increase the heart rate, you touch the heart rate, but you get an arrow, whether to scroll it up or scroll it down. You can increase or decrease the heart rate. Same with all the parameters. It's very, very user-friendly, very easy to do. This can be connected either to a laptop or to your monitor. And the tones are very real. So if the saturation goes down to, say, 70, it will sound exactly like saturation of 70. So it feels very realistic for whoever is there, and it can be used in periphery. It doesn't have to be in a big center. So this is how we can easily change vital signs. I'm not advocating any company. Just put simulate and it will come up. Third is video playback. I think it's absolutely crucial, and I'm going to show you some videos why this is important. People do not remember what they say or how they behave when they're under stress. For example, I'm giving this talk. I may not be aware of my mannerisms because I'm trying to. So it's very important. It is recorded and then played for the whole team in a non-threatening way, and everyone can learn from it from each other. So please take consent and ensure that they give consent for recording. And it has to be a dedicated device. We don't want this to be shared outside. So it's going to be in OR. You record it. If you want to use it for training, yes. Otherwise, you can delete the video, and it's done. Please use one of the tools we looked at earlier. It can be ANTS or Notex. One of these feedback standardized tools, and then you can have a debrief. You can connect it to a laptop, and so that everybody can watch. So if you look at it, you can have a simulation center wherever you work. You do not need a dedicated center, and you can do it during your on-call time. You don't have to wait for a dedicated. If you get dedicated time, great. But the way the world is going, we may not be able to get this, and we have to adapt and see how we can do this. I'm going to go through a few videos. These are all non-medical videos. This is from an episode of Friends. It's one of the sitcoms in US. So the gentleman near the door is called Ross, and he wants to get a fake tan. It's a spray tan just to look like you're tanned. And the first video shows a really good example of feedback loop. So feedback loop is one person is giving instruction, other person understands and repeats it back. So What we'll do is I'm going to play the video and you see if there is a good feedback loop and let me know.
The red light. When the red light goes on, the spraying's about to start, so close your eyes. When the spraying stops, count to 5. Pat yourself down to avoid drip marks, then turn around so we can get your back. Got it? Spray, count, pat, and turn. Spray, count, and pat.
So, do you think Ross actually understood? So he repeated the instructions very clearly. So the gentleman in red t-shirt gave the instructions. So he has to get his front and he has to get his back. Many times, people may repeat this back to you. And let us see what actually happens when he goes to the spraying area.
1 Mississippi, 2 Mississippi, 3 Mississippi.
So the instruction was clear. It looked like he understood, but something went wrong. So this is why video recording is important. Let us see what Ross has understood and what the other person has given instruction, and let us see if the feedback loop was actually completed or not.
Front twice. Never turned? No, I barely even got to 3 Mississippi. Mississippi. I said count to 5. Mississippi, listen.
So if we ask you to count to 5, how would you count? In US, they use this Mississippi word, but he said count to 5, and he added a word in between which delayed his counting, and you could see what happened. So instead of getting his bat, he sprayed twice in the front with the tan. Actually, what happens in the episode is he goes back in again and gets 2 more sprayed in the front because of misunderstanding. The same thing happened to us in our hospital. Once there was a PPH, and we use a system called as level 1 to infuse blood and blood products rapidly. So we asked one of the porters to go and bring us level 1. So I said, level 1. He said, yes. So he disappeared and he did not come back for a very long time. We sent someone else, we got the equipment, and then we tried to figure out what happened. So that person thought level 1 is first floor. So we are in 3rd floor, our OR is in 3rd floor. So he actually went down to level 1 and he was just walking around because he heard the term level 1. So these things can happen in real life when people are stressed. So Ross goes back to another tanning place because he gets fed up with this place. Now he's sprayed 4 times in the front, nothing on his back. So he wants to get everything on his back. In the next video, I want you to observe 2 things. One is behavior of Ross, but more importantly, the face of the other girl. Please, at the end of the video, just observe the face.
Explain how this works. You go into the booth and you
I'm going to stop you right there, Glenda. Okay. Does it look like this is my first time? Huh? Now I want 4 2s, and I want them all on my back.
Just look at the face. So we talked about psychological safety in Google. So do you think that girl feels psychologically safe? If Ross is going to do something wrong, do you think this girl is going to say anything about it? And if you have a video and if you show this to Ross, probably he does not realize he's saying this, but it's a very, very powerful way. Just don't talk and just let them see the video and they learn so much from it. But let us see what happens when Ross goes inside and observe what happens.
Wait a minute. There's 2 sets of nozzles. Which one is it? Which one is it?
Sorry for the swearing. So this is what happens when someone is trying to help you and give you an instruction. We don't listen. When we are relaxed, we may be very different people. But when we are stressed, we may do things which we don't realize. And this is where video feedback is absolutely crucial. And it's very, very useful. So you're probably all wondering what does Ross look like after all this? And I'm just going to show you 3 photos. So the one on the left is that's how he looked right at the start. The one in the middle is how he looked halfway through. You can see the tan in the front and nothing in the back. And the last one shows how he looked after 8 tans right in the front. So video feedback, very useful. So to summarize, you need to know who your team is. It's not what we think our team is. Anyone you need to get your job done is part of your team. Please go back, look at their face, say hi to them, know who your team is, because you never know when you're going to need them. It could be pharmacy, it could be procurement, it could be blood bank. It's very important. they must feel psychologically safe to give us some ideas. So, for example, transferring patient, we are doing some research based on this now. Simple things, they can have excellent ideas, and unless we are willing to listen, they may not tell us this. What ifs and mental models are very, very, very easy way. You can do it wherever you are with your team. Absolutely crucial. Very simple way of getting the basics absolutely right. And simulation does not have to be high fidelity. Simulation, you can use very simple tools to conduct simulation wherever you're working. It's absolutely fine. You do not need state of. So these are the key takeaway messages from my talk. So know your team, understand what you need, what ifs, and simulation can be very simple. And it's very important to make it a habit. Habit is spelled H-A-B-I-T. If you remove H, a bit remains. If you remove A, bit remains. If you remove B, it still remains. So whether you work there or not, your team will pick up excellent habits. Thank you.
Very interesting talk. It was fully laced with good examples, normal day-to-day examples, which everybody understands very conveniently, and they can utilize them in their day-to-day practice as soon as they leave this webcon. But there are a couple of questions which we have received. We have always faced these questions earlier also, and it seems they are very frequently asked questions in this field. One question asks, do you think experience, gray hair, long tenure in the field makes a leader? Or is it the expertise?
Hi, thank you. Leader is born or leader is made? Is that the question?
Yes. So if I'm senior and if I'm sent to a unit where I have not been ever before and there's a emergency there, so am I the leader?
No, not really. I think that's a misconception. So seniority does not mean you are the leader. Yes, you're most experienced. A team leader is one who can understand the whole situation, stand back, does not need to get involved in any task, and have a good overview and guide the team members what is the right thing to do. That's pretty much the role of a leader. It does not have to be someone who is most experienced. It can be someone who is least experienced, but who can stand back and look at the whole situation in a good way. Has that answered your question?
Yeah, I'm sure it has answered the query of the delegate. But at the same time, KK, it so happens so many times, if a junior is, heading the team, he's a leader, and there is a conflict, there's a disagreement in some decisions taken by the leader, then how does one tackle those without, making a war?
Fantastic. Okay, I think that's very useful question. And there is actually a very nice strategy to go through this in a non-threatening way. So it's a 4-step strategy. First is, suppose someone senior, as you say, so you have and someone is going to give penicillin for a patient who is penicillin allergic, for example. Okay, so the first is ask. So just gently probe. Okay, it's called as a PACE strategy. First is you probe. So probe and ask, sir, do you know this patient has got penicillin allergy? So you are just probing. The person will be grateful to you for reminding him. He may not even know this patient was penicillin allergic, or his mind may be someone else. So what you've done is, in a very non-threatening way, probed or alerted that person that the patient may be penicillin allergic. Are you aware? If they don't listen to that and they still want to give, then you ask, so which is P, and next step is A. You ask them and say, this patient is penicillin allergic. Are you sure you still want to give penicillin? So you're asking a question, are you sure you still want to give penicillin? Third is you challenge, which is, this patient is penicillin allergic, you should not give penicillin. Does it make sense? So PAC. And last is you physically stop them. That means you hold their hand because they're still not listening to what is happening. So PACE, very easy to remember. Probe, ask, challenge, and then engage. That's it. I hope that helps.
Yeah. So after this all has happened and we have done a successful work, Do we have a team debrief?
Definitely, yeah. I think that's one of the thing which I said. You always, it's a must. If you can have a video debrief, even better. But otherwise, have a structured debrief. It should be non-threatening and it should be a way where everyone can learn. It has to be a very friendly debrief. It does not have to be, who is right, who is wrong. No, that's not the whole idea. It's about what we are going to learn from this and what we are going to change next time. It's not about person, it's about system.
Okay. Absolutely correct. So I'm sure people have gathered all the information, and I'm sure they're going to bring it into their clinical practice. Thank you very much. Please stay on because we are sure to receive some more questions. They were very good questions, and people are still typing. Your lecture was being heard by close to 800 live streaming, so I'm sure there will be some more questions coming up. In case you are there at the end of the session, I will take the liberty of asking you again.
Thank you so much. Thank you.
Okay. Thank you very much.
Absolutely. Thank you.
Thank you very much. So when we move on to in today's program, and we have our third faculty who is with us in the speakers gallery, I have this pleasant duty to introduce Dr. Arvind from St. Louis, USA. He is the Division Chief and Fellowship Director of Obstetric Anesthesiology at Washington University there. He's in the editorial board of a prestigious journal, Anesthesia, as well as International Journal of Obstetric Anesthesiology. He's member of the ASA Task Force Committee on Obstetric Anesthesia. And he has received many prestigious awards due to his active research activities. And they are very famous awards, like the Gertie Marks Award in 2007 and then again in 2009. He was awarded a Best Scientific Paper in the SOAP meeting in 2011. Besides that, Arvind is a very good friend. He's an alumni of All India Institute of Medical Sciences, India. And I feel extremely proud to be introducing him to speak on a very important topic in today's world, that is pregnancy and COVID-19. We all know that COVID-19 has stimulated a lot of questions in our mind, especially when it concerns pregnant women, like, are pregnant women at higher risk from COVID-19? How can I protect a pregnant woman from getting COVID-19? Should they be tested? We have to take them up for C-section? What will happen to the newborn baby? Will the newborn baby also get it? And so on and so forth. So this is a very vital topic which Dr. Arvind is going to address, because he was at the helm of affairs in dealing with such women during this pandemic. Over to you, Arvind.
Hi, can anyone hear me? Hello?
Yes, we can hear you, Arvind. We can
Perfect. Okay. Thanks for the wonderful introduction, Dr. Kajal Jain, and a good evening to everyone. It's about, I think it's 4:15 in the morning for me, and I'm actually nice and sparkly. So the purpose of this update was over the past 10 months or so, we've actually learned a lot about the disease, either by reading the literature or by reading WhatsApp forwards. So the purpose of this talk is to actually put all the information together and give you an update on what's known and some of the outstanding questions for which we don't have the answer. I'm also being a very optimistic person, and I hope that this would be one of the last discussions on the topic, and I hope we can kind of move forward with our lives without COVID-19. So the way to look at this particular question on COVID-19 during pregnancy is to ask ourselves a few questions. One is, what is so unique about COVID-19 in pregnancy? What is pregnancy, the state of being pregnant, due to COVID-19 as a disease? What does COVID-19 do to pregnancy in terms of the outcomes of pregnancy, such as cesarean delivery or preterm birth? And then we should probably think about some special topics, such as the immune response in pregnant women to COVID-19, as well as the possibility of vaccination. So I think if we can have these broad frames for discussion, I think it'll be a very, very good tool to spend in the last 5 minutes after the topic is over. So what is unique about pregnancy? There are many facets that are unique, but the one that I really wanted to highlight are the immunological changes, because they have a direct bearing on the disease process of COVID-19 in pregnancy. There are a lot of changes in the immune system that happen during pregnancy. A lot of people call it immunosuppression, but it's a little bit more nuanced than that. It's more immunological indolence or laziness. And I say that because not many arms of the immune system are suppressed. In fact, some are actually intact or even upregulated. For example, cell-mediated immunity kind of starts to go down in the second trimester, whereas the humoral response, the humoral-mediated immunity, is either intact or upregulated. So it's much more nuanced than a broad immunosuppression during pregnancy. So if you look at it from a trimester perspective, obviously we don't have much data from the first trimester, but starting from the second trimester onwards, you'd notice that the T cell mediated immunity starts to go down all the way through third trimester, whereas the humoral immunity mediated by polymorphonucleus cells, the alpha defensins, they tend to go up. So there's kind of a nice divergence of the two arms of the immune system in pregnancy. And the consequence of this is that pregnant women are susceptible to infections, certain type of infections, especially viral infections, such as influenza, hepatitis E, and HSV. Obviously, COVID-19 is caused by SARS-CoV-2, which is a single-stranded RNA virus, which is similar to influenza. So just to highlight one of the reasons why pregnant women are susceptible to viral infections, especially in the third trimester, I just wanted to share the snapshot of the outcomes of the pandemics that have happened in the past. So I've just focused on the influenza pandemic from 1918, 1957, and the most recent one, which was the H1N1 pandemic in 2008 and 9. So you can see that if you look at the ICU admission rates, and obviously we didn't have much data for 1918 and 1957, but for the H1N1 pandemic, it's about 5 to 9%, both the ICU admission rates and the mechanical ventilation rates. But if you look at maternal mortality, you see that in the 1918 pandemic, almost 1 to 2 out of 4 pregnant women with influenza A actually died. It's really, really high. And this was actually reflected in the H2N2 pandemic in 1957. And even if you look at the most recent influenza pandemic, there was approximately 4 to 5-fold increase in the rate of hospitalization and mortality if you were pregnant. So pregnant women are clearly more susceptible to increased severity of disease. But there's something very unique about SARS-CoV-2 or COVID-19 infection in pregnancy. And one of the first things that came out early on in the disease was the high incidence of asymptomaticity. I've never come across an infection that causes no symptoms, especially seem to be much higher in pregnant women. In fact, you must have all looked at this paper by Sutton that was published in the New England Journal of Medicine, where they tested all the women entering labor and delivery for either induction of labor or for C-section. The rate of asymptomatic infections was almost 88%. And this was reflected in other studies from other hospitals in the United States at the peak of the crisis in March and April of last year. It's about 73% and about 45% in the Harvard-affiliated hospitals in Boston. So that's very unique about COVID-19 in pregnancy. And the second unique feature is, unlike all the mortality rates that I showed for influenza, you notice that for COVID-19, the mortality was either similar or comparable to other age and sex-matched populations. For example, the incidence of mild infections were almost 90%, for pregnant women, and there were no mortalities, at least in the initial reports that came out from different parts of the country. So I'm presenting data here from China, from Italy, and from the United States. So this was kind of the initial impression that I had when I started looking at COVID-19 in pregnancy. So the question then becomes, okay, is it relevant? Does it happen at my institution? And so I worked with Dr. Jeannie Kelly, who was a maternal fetal medicine specialist at our institution, and we asked the same question. Do we have a high incidence of asymptomatic infection in pregnancy at our own institution? And so what we did, we had a policy of universally testing every patient undergoing surgery at Washington University. And what we did was we compared the incidence of asymptomatic infection in SARS-CoV-2 positive patients. And we kind of separated them into those coming to labor and delivery for either C-section or induction of labor, and those undergoing general surgery. So there were about 5,500 tests that were done in that 2-month period. And what we found was that pregnant women had almost a 5-fold increase in the incidence of asymptomatic infections. But if you exclude males from the population, especially from the surgical units, and if you compare only a pregnant female with a non-pregnant female, the odds ratio for having asymptomatic infection was almost 10-fold higher. So clearly, there's something biological about pregnancy that caused a much higher asymptomatic infection compared to the non-pregnant female. So I was actually very intrigued by this observation, because very rarely you come across asymptomatic infections, for example, with influenza. And so I started looking into the mechanisms by which this could happen. And in order to understand that, you need to know some of the basics of the pathogenesis of COVID-19 in pregnancy. So the SARS-CoV-2 virus attaches to the cell through 2 mechanisms. Obviously, we all know that the receptor for SARS-CoV-2 is the ACE2 enzyme, which is the angiotensin converting to enzyme, which binds the virus, the spike protein in the virus. But what we don't know is that it is, and there's another protease called the transmembrane serine protease that is co-expressed with ACE2 in the cells, which is responsible for cleaving that spike and allowing the cell membrane of the virus to fuse with the cell membrane of the cell. And both of them are essential for the virus to enter into a cell. And so I was asking the question, is there anything unique about pregnancy? Do pregnancy hormones interfere with the expression of one of these factors? And so what I did was I had a rat model to study a different topic, but I thought, well, this might be a good question to explore. And so what I did was I dissected out the nasal epithelium of term pregnant rats and compared them with a non-pregnant female rat, and specifically looking for the expression of the angiotensin converting to enzyme and the serine protease. So on the top left panel A is the gene expression. The gray column is the non-pregnant rat, and the pink column is the pregnant rat. And you can see that both ACE2 and TMPRSS2 genes are profoundly downregulated during pregnancy. And the same thing is reflected when you look at the protein, where we did Western blots to quantify, and that's represented in panel B. And in panel C, we also check the activity of the enzyme, because angiotensin converting enzyme is an enzyme with an activity. And so we tested the activity, and we found that to be decreased by about 50% in pregnancy. And while we were doing that, I also asked the question whether there's something unique about the innate immune response at the level of the nasal epithelium, which is the primary portal of entry. And so we looked at some of the genes that are essential for offering some degree of protection by means of sensing the virus and initiating an immune response. And I want you to focus on the panel E, and there are a couple of genes there that I've highlighted. It's RIG1, TLR is a toll-like receptor 7, which is very important for mounting an innate immune response. And here you can see that with pregnancy, represented by the pink bars, there's actually a profound upregulation. So that took me by surprise, because we are always operate under the assumption that pregnancy is a state of immunosuppression. But what I was finding at the level of the nasal epithelium was that there was an upregulation of innate immunity. And so I thought, well, nature would not design a flawed system, and so maybe there's some reason why it exists. So My take on this is that there's probably some kind of immunomodulation at the level of the placental fetal interface so that the mother can tolerate the antigenic fetus, but that is not reflected in other regions. So there's probably some organ-specific immunological adaptation during pregnancy. So what about the incidence of severe COVID-19 in pregnancy? So we talked about the overall possibility that the mortality was low, but I also highlighted that the incidence of asymptomatic infections is much higher. So if you include all of them together, the denominator becomes a large number, and therefore it gives a misleading result that the incidence of severe disease is low. So what the CDC in the United States did was to actually compare the risk for ICU admission or the need for mechanical ventilation in symptomatic patients. So for example, if you exclude all the asymptomatic pregnant infections out of the picture and just compare pregnant women with symptoms to non-pregnant individuals with symptoms, you can see that the rate of ICU admission goes up almost 3 to 4-fold. And so is the need for mechanical ventilation. The overall mortality rate still is comparable, but because of the large numbers, you can see the numbers in this particular surveillance study by the CDC, including data from the entire United States. It's almost 24,000 patients who are pregnant and about 400,000 patients who are non-pregnant. Even though the death rate was significant, the overall mortality rate was still low. So my take on this topic is that you have a high proportion of asymptomatic infections, but if a pregnant woman has symptoms, then their risk for getting to the ICU or the need for mechanical ventilation is much higher than someone who's in the same age group and is not pregnant. So that's an important point to remember. So any pregnant woman coming with symptoms suggested for COVID-19 is certainly at a slightly higher risk for ICU admission. So obviously, one of the problems with the CDC data is that they didn't match for the comorbidities between pregnant and non-pregnant women. And to address this, this group in France actually did a propensity score match analysis. And what the propensity match does is that it makes sure that both the case group, which is the COVID-19 pregnant group, and the control group, which is the COVID-19 positive but non-pregnant group, are well matched for comorbidities. So you would make sure that they are matched for the incidence of hypertension, diabetes, body mass index. So once you match them, then the results become much more striking and powerful. So in this particular study, they looked at the ICU admission as the primary outcome. And here it's very obvious that if you're pregnant, which is represented by case group 2, there's almost a 5-fold increased likelihood of being admitted to the ICU. And the same thing holds good for the need for intubation and the need for oxygen therapy, as well as the need for ECMO. So it's very obvious that if you have a symptomatic pregnant woman, the likelihood of needing critical care or intensive care is much higher. Again, we wanted to see if this data was applicable to our institution, and Megan Oakes, one of the maternal fetal medicine fellows, looked at data from our own institution. And what we looked at was the incidence of severe disease, and we used 2 different criteria to define severe disease, using either the novel coronavirus epidemiology tool or the WHO ordinal scale. Regardless of which scale you use, the overall incidence of severe disease was 3 to 5-fold higher if a patient was pregnant compared to a non-pregnant patient, as long as they have symptoms. And if you look at the ICU admission rates, that's almost a 10-fold increase in ICU admission if you are symptomatic and pregnant. So these are striking data. And so these kind of deviate from the initial impression that pregnant women are less likely to need. So if you exclude all the asymptomatic infections, a much more nuanced picture emerges. So we learned about what the pregnant state does to COVID-19, but it's also important to know what COVID-19 does to the state of pregnancy. And there are many studies out there, but I wanted to highlight a meta-analysis that was recently published in the British Medical Journal. This included almost 77 studies all the way through, I think, the end of October. And what they looked at was pregnant women with COVID-19, and the comparison group was pregnant women who did not have COVID-19. And they basically looked at all the perinatal outcomes, including stillbirth, the need for C-section, preterm birth, admission to the NICU. And you can see that clearly. If you have COVID-19 and if you're pregnant, the chances of having a C-section is about twofold higher than if you don't have COVID-19. The risk of preterm birth less than 37 weeks is about threefold higher. And the risk of NICU admission is about threefold higher as well. So clearly, the outcomes are not great for the babies, but this is something for you to consider, especially if you have a COVID-19 patient, and if you're in a small clinic, you might want to refer those patients for delivery, especially if they're less than 37 weeks, to a tertiary referral center. So one of the questions that often comes up is the vertical transmission question, because ACE2 expression does occur in the placenta. So the picture on the top left is a single-cell RNA sequencing data from human placentas, and you can see a lot of colors represented there, and each color represents a particular cell type in the placenta. So I want you to focus on these two here. So the green dots represent ACE2 expression, and if you look really closely, you can see some blue dots which represent TMPRSS2. And remember that you need both for the virus to enter into the cell. And ACE2 seems to be reasonably expressed in the villus cytotrophoblasts and the stromal cells, but TMPRSS2 not as much, especially the first 6 to 14 weeks of pregnancy. So it's unlikely that vertical transmission occurs early during pregnancy, just based on the expression of both ACE2 and TMPRSS2. It is expressed, but not to a great extent. And more importantly, TMPRSS2 is not co-expressed with ACE2. And if you look at all the data for SARS-CoV-2 infection and first trimester outcomes, broadly, there are only like two major studies that looked at it, and there's no impact on either fetal development or pregnancy loss. In fact, in one of the case control studies from Italy, there was no overrepresentation of COVID-19 in a group of women who had a spontaneous abortion. And then there was a study from Denmark that actually looked at COVID-19 in pregnancy in the first trimester and saw whether there was any impact on the nuchal thickness, which is usually considered a marker for abnormal fetal development. And women who were positive for SARS-CoV-2 did not show any impact in the sense that there was no increase in the nuchal translucency thickness in the babies, nor was there any evidence for spontaneous miscarriage in SARS-CoV-2 positive women. So these findings are very reassuring. If you get COVID-19 during the first trimester, it's extremely unlikely that it would affect the baby. And these are completely different data compared to, for example, the Zika virus, where the virus per se does not affect the mother, but definitely transmits very readily to the fetus and can cause fetal CNS infection. So these are pretty reassuring data for COVID-19. So the next question is about, what about vertical transmission at birth? This is what we are always concerned about. And one of the most recently published, this was published just about 4 days ago. This is a meta-analysis by Cochlear et al. That looked at almost 936 neonates that were born to COVID-positive moms. And they looked at all the different sites. So this is a meta-analysis, all the case control studies, the cohorts, and the case. And only 27 babies out of the 936 actually were positive for SARS-CoV-2 RNA in the nasopharynx. So the first column is the nasopharyngeal swab. So the overall transmission risk seems to be about 3%, and it's been replicated in a bunch of other studies. So it is unlikely to be clinically relevant, and our policy in general is to keep the mother with the baby because it's highly likely that the mom is positive as well. And so if someone asks you, hey, what is the possibility of transmission at birth? It seems that there's a general consensus that it's about 2 to 3%. So that's a good number to know. And but you don't have to make any changes in the way the mom looks after her baby. So let's move on to a more interesting topic, which is the immune response in COVID-19. So it's really important to know what happens to the IgM and IgG levels. And this is kind of a snapshot in normal non-pregnant individuals. And if you look at what happens in a non-pregnant patient, this was a great data that was published in Science. On the left, you have the antibody titers and the degree of neutralization along the vertical axis. And you can see that the more antibodies you have, the more likely you're going to neutralize the virus. And that's kind of the bottom line of the overall impact of the immune response. So the more severe symptoms you have, the more the amount of antibodies you have, and the more likely you're going to neutralize the virus. So the interesting question here is, do pregnant subjects show a similar response? Because there's not a lot of data out there for pregnancy. And you can here clearly see, so this is one of the first studies that I came across from medRxiv. This is not published yet, but this is data coming from a very reputable institution, the Johns Hopkins, where they actually looked at immune response in pregnant women compared to non-pregnant women. And they chose a variety of antigens, the S protein, the anti-S-RBD, which is a receptor binding domain, as well as the neutralizing antibody to the entire virus. They looked at many of these aspects. And I want you to focus on the graph at the top here, which is the anti-S spike protein IgG. And the orange circles represent the pregnant women, and the black circles represent the non-pregnant women. And you can see that the immune response seems to be muted for some reason. These are symptomatic COVID-19 subjects. And you can see that if you're pregnant, you're not really mounting a more vigorous immune response compared to non-pregnant subjects. So that's kind of a little worrisome in the sense that can these patients become more vulnerable to SARS-CoV-2 again at some point? We don't know. But this is the data that's out there. And which is the graph at the bottom. So you can see that there's a pretty considerable transfer. So the amount of antibodies in the cord blood serum is pretty similar to what's there in the mother. So these are IgG antibodies. Obviously, IgM, because they are bigger, they do not cross the placenta, but there's some evidence for transfer of IgG antibodies. But I want to put in a word of caution because you can see the sample sizes here. It's about 17 patients. So there's not a lot of good quality data, but this is the only data that's out there that kind of gives us an idea of the immune response during pregnancy. But more importantly, this is immune response to natural SARS-CoV-2 infections. We don't know how pregnant women are going to respond to vaccination, especially the mRNA vaccines, which are a completely new beast when it comes to the vaccine world. Highly effective, but we don't know how they're going to work in pregnant women. So I think that should be an important message to be communicating to people when someone asks you about vaccination during pregnancy. So one of the most controversial topics everywhere in the world right now is, do pregnant women need to be vaccinated? And the problem is that because of ethical reasons, pregnant women were excluded from all the clinical trials. In fact, there should be an ethical argument to allow pregnant women to participate in trials if they wish to do so, because even after these wonderful clinical trials involving 40,000 patients, we still don't have any good data from pregnant women. So what we really need is what's called DART data, which is developmental and reproductive toxicity studies. And these are studies typically done in pregnant mice as a preclinical study before they roll it out to humans. I was told that Moderna has some data that's very promising, that it doesn't have any impact on pregnancy, but I have not seen it published. One of the questions that keep coming up is the impact of mRNA vaccines. Remember that these mRNA are packaged in lipid nanoparticles. They are about 10 to 100 nanometers in size. And they can easily cross the vaccine, which is a completely different beast. And so they cannot recommend these vaccines without having 100% assurance that they are safe for the mother. My take is that it's going to be extremely safe, but we need to see some data before rolling it out to pregnant women. So all the organizations say that pregnant women, especially if you are a healthcare worker, you should consider taking the vaccine, but otherwise you need to talk to your provider to have a risk versus benefit analysis. So that's kind of the bottom line at this point. And I'm hoping that both Pfizer and Moderna would come out with some data from pregnant women in the next 2 to 3 months. So with that, I think we should wind down by summarizing what we have kind of learned so far. So what is unique about COVID-19 in pregnancy? Obviously it's the high asymptomatic infection rate that I talked about. But if they are symptomatic, there's a very high incidence of critical care need and an increased risk of complication. But the good thing is that the mortality appears to be no different from an age-matched population. So these are unique things about COVID-19 in pregnancy compared to previous pandemics in pregnant women. So what does the state of being pregnant do to COVID-19? Well, I showed you some data from my own lab that pregnancy may decrease the expression of all the receptors that are necessary for the entry of the virus. There's a possible increase in innate immune defense, and I'm actually following it up with some human studies. And so it is possible that there's a very unique host pathogen interaction when it comes to SARS-CoV-2 in pregnancy. And what does COVID-19 do to pregnancy? Obviously, there's a much higher risk for preterm birth. There's a twofold increased risk for C-section. But if it happens during the first trimester, there's no risk of a spontaneous miscarriage and no risk for vertical transmission early in pregnancy. And finally, when we talk about the special circumstances, I showed you some data that the immune response to a national infection is suboptimal. Unfortunately, we don't have any vaccine data, but it's likely that the immune response is likely to be muted. We don't know what the lipid nanoparticles would do. And in fact, there's some data that's just coming out that one of the lipid components called the polyethylene glycol, PEG, has been shown to be the one that's responsible for some of the allergic reactions and the anaphylactic reactions that's been reported with the Pfizer vaccine. So we need to keep an eye on it. It's definitely much higher than your typical allergic reaction with other vaccinations, but it's still overall, it's still a low number, but we need to keep that in mind. So it always comes down to risk-benefit analysis. So if you're a pregnant healthcare worker, taking care of patients, then I think it might be a good idea to get the vaccine. But if you don't have any risk of exposure to SARS-CoV-2, I think you should be okay. So with that, I'd like to conclude my talk, and I'm happy to take questions. Thank you very much.
Thank you very much, Arvind. That was a very elaborate view on COVID and pregnancy. Well, we have some questions, but are you going to stay on so that we can take these questions at the end of the session? Are you going to stay on?
Absolutely. Yeah, absolutely.
So
yeah.
I have some good number of questions because, as you know, COVID interests everybody today, and more so when it is concerned with the pregnancy too. So I'll really appreciate if you stay on and we can ask you at the end of the day. Will you be there?
Absolutely. So what time do you think the session
That would be 8:20 p.m. of India.
Okay, perfect. Yeah, absolutely. I'll be happy to answer questions.
So we move on, and we have Dr. Bateman with us, and I welcome Dr. Bateman. It's early morning, and we are very grateful to him to have woken up in the wee hours of the morning, 5:52 a.m. currently. So Dr. Bateman is faculty at Harvard Medical School, Brigham's and Women's Hospital. He's in the editorial board of a very prestigious journal, Anesthesiology. He has written the current Chestnut Obstetric Anesthesia Principle and Practices, a few chapters in that book. He holds a lot of strong administrative positions. To name a few, FDA's Anesthetic and Analgesic Drug Products Advisory Committee, Joint Commission Expert Reviewer for the Agency for Healthcare Research and Quality on study sections at NIH and PCORI, and Grant Review Boards for funding agencies from several other countries. He serves on the board of directors for the Society of Obstetric Anesthesia and Perinatology. And today we have Dr. Bateman speaking to us on risk stratification in obstetric anesthesia. Over to you, Dr. Bateman.
Well, thank you so much. Thank you for that kind introduction, and thank you for the opportunity to speak with you. Greetings from Boston. So this is the outline for my talk. I'm going to start off by describing what's known about the epidemiology of maternal mortality in the United States, and we'll focus on the major causes of maternal mortality and what's known about preventability of maternal mortality. And that data really underlies the motivation for the use of early warning systems and the way in which the early warning systems are that we use on obstetric units are defined. I'll go through some of the data that we have to support the use of early warning systems and the impact of early warning systems on improving obstetrical outcomes and maternal safety. And then I'll close by switching gears a little bit and talking about ways of risk stratifying patients based on their comorbidities. And I'll describe a system that we have developed, the Obstetric Comorbidity Index, and which is now used in our routine clinical practice, both at our hospital, the other hospitals across Harvard, and several other leading institutions throughout the United States. So this is data from our Centers for Disease Control and Prevention showing the cause-specific proportionate pregnancy-related mortality for different types of complications for different time periods. And what I want to draw your attention to here is the major causes of maternal mortality. So hemorrhage, hypertensive disorders, infection, thrombotic pulmonary embolism, cardiovascular conditions, and cardiomyopathy. These are the leading causes of maternal death in the United States. My expectation is you'd see perhaps a different distribution, but many of these same causes in India as well. So what's important is that the vast majority of these, or the great majority of these maternal deaths are at least possibly preventable. So these are data from the state of California, from their Maternal Mortality Review Committee. The committee reviews all of the deaths that occur in the state, and they go through the charts and have experts look at the care that was provided. And then the committee judges each of the cases and grades them as having a good chance, a good to strong chance that the outcome could have been better or could have been averted with better care, some chance that the outcome could have been averted with better care, and no chance. And so if you look at the proportion that are judged to have a good to strong chance for some indications like obstetric hemorrhage, the preventability rate is about 70%. And you can see the other causes, some of the preventability numbers are quite high. When you further include the cases where there was at least some chance that the outcome could have been avoided with better care, you see here the estimates are in upwards of 80-90% for most of the indications, suggesting that a large fraction of maternal mortality is in fact preventable with optimal care. So why do these deaths occur? Why does suboptimal care why is suboptimal care provided? And when these cases are reviewed, two key themes emerge. Denial by the practitioners regarding the seriousness of maternal condition, and then delays in timely evaluation of the patients, timely diagnosis of the complication that the patient's experiencing, and delays in timely intervention. So why does denial occur? Why do we have these delays? Well, labor and delivery units are very busy places, and in the operating room as anesthesiologists, we're used to taking care of one, maybe two patients at a time. They have our complete attention, and we're following their vital signs minute to minute. On labor and delivery units, in contrast, we're often caring for many patients at the same time. At the Brigham and Women's Hospital, we have 24 labor rooms, so we're managing a large number of patients simultaneously. The other issue is that young women compensate well, so they can have a large amount of blood loss before they're going to really manifest major alterations in vital signs, for example. The other issue is adverse events can occur in low-risk patients. We know about half of the really severe cases of maternal hemorrhage occur in patients in the absence of recognized risk factors. And so it's not that all of the bad things that happen occur in a small subset of very high-risk patients. And then finally, vital signs are often abnormal in pregnancy. Everyone who works on a labor and delivery unit knows that tachycardia is not uncommon when patients have pain with labor contractions. A little bit of hypotension after the placement of a epidural or a spinal is also quite common. So sometimes we're desensitized to the aberrations in vital signs that are occurring, which can lead to us ignoring what should be quite worrisome vital signs. So early warning systems are really designed to avoid the dual trap of denial and delays that we know underlie so many cases of preventable severe maternal morbidity and maternal mortality. So obstetric early warning systems were originally developed for use in ICUs and on medicine wards, but their use has been extended to obstetrical settings. And the notion is that these early warning systems can alarm and alert teams to abnormal signs and symptoms that may precede critical illness. And in doing so, they can prompt the urgent or even emergent evaluation of patients by the anesthesia team, the obstetricians, so they can then determine if, in fact, the patient is having a complication that needs to be addressed. And in doing so can facilitate early intervention and thereby prevent the progression to morbidity or even maternal death. So in the beginning of the talk, I reviewed the most common causes of maternal death in the US, the data from the Centers for Disease Control and Prevention: hemorrhage, sepsis, VTE, preeclampsia, and cardiovascular complications. And the signs and symptoms for each of these complications are listed here. So for hemorrhage, tachycardia, hypotension, altered mental status; sepsis, fever, hypotension, tachycardia, hypoxia, altered mental status; VTE, tachycardia, tachypnea, hypoxia, preeclampsia, severe range blood pressures, hypoxia; and then finally cardiovascular complications: tachycardia, bradycardia, hypoxia, and hypotension. So these are the signs and symptoms that are going to be typically integrated into early warning systems to allow for the identification of these complications and conditions occurring. So when these systems were originally proposed and their use was advocated by national guideline organizations, national patient safety organizations, it was really based on expert opinion, the notion that if we use these tools, we're likely to identify patients that are high risk, and that's likely to improve the outcome. But this study by Larry Shields and colleagues really sought to provide data to answer the question: can maternal morbidity be reduced through the use of a maternal early warning trigger tool tied to clinical protocols? We tried to develop robust data to either support or refute the use of early warning tools in obstetrics. So they designed a study that occurred across 29 hospitals in the western part of the United States. 6 of the hospitals were identified as pilot sites where an early warning trigger tool would be implemented, and then 23 hospitals were identified as control sites where data on maternal morbidity was collected, but the early warning trigger tool was not implemented, and these acted as controls. So their tool, and I'll show you in the next couple of slides the way their trigger tool works. If the tool alarms, the patients are to be evaluated by the OB or anesthesia providers, and then if they have one of 4 complications, so hemorrhage, hypertensive disorders, infection, or cardiovascular complications, they're put on treatment pathways to manage these most common sources of maternal morbidity. The primary outcome for their study was a measure of severe maternal morbidity based on our CDC's definition, so something that integrates maternal end organ injury into a single measure. And they assessed the occurrence of the primary outcome as well as several secondary outcomes that I'll describe in a 24-month baseline period, and then compared it to a 13-month post early warning trigger tool introduction study period. So this is their early warning trigger tool. The patient would trigger if she had a single vital sign in the severe range, so heart rate greater than 130, respiratory rate over 30, blood pressure, mean arterial pressure less than 55, or an O2 saturation of less than 90, or two abnormal values in the non-severe range. And you can see the vital sign boundaries for each of the non-severe ranges. They also included both fever and hypothermia as non-severe measures, fetal heart rate greater than 160, or altered mental status or severe maternal pain. So these are the data showing the impact. In the left-hand column, we have the hospitals that introduced the early warning trigger tool tied to the clinical protocols. And on the right-hand side, the non-pilot sites, the control set hospitals that I mentioned. On the top line, you see the CDC severe maternal morbidity measure. They also looked at a composite morbidity measure that included some measures of obstetrical hemorrhage and transfusion. They looked at eclampsia, the occurrence of hemorrhage, transfusion overall, D&C, the need for peripartum hysterectomy, or a diagnosis of sepsis. And you can see there was a statistically significant reduction in the CDC-defined severe maternal morbidity measure, the composite morbidity measure, and the occurrence of eclampsia, and a trend towards a reduction in all of the other measures of maternal morbidity, with the exception of sepsis, which increased slightly after the introduction of the tool, potentially due to just increased diagnosis of that condition. In contrast, looking at the control sites, the occurrence of severe maternal morbidity during the same time period was either stable or increasing, suggesting that the observed reductions in the pilot sites were really due to a causal effect of the introduction of the early warning trigger tool and not due to other secular trends or other changes in practice that were occurring across healthcare coincident with the introduction of the early warning trigger tool. So they then went on to look at the performance characteristics of the tool, how sensitive it was for detecting patients that went on to deteriorate, and they found quite a high sensitivity. So 97% of the obstetrical patients that ended up in the ICU triggered, which is great sensitivity. They also found a low frequency of triggering. So one of the things we worry about with early warning trigger tools is that there's going to be a high frequency of triggering leading to alarm fatigue. But in fact, here with the tool that I just described, the frequency of triggering on labor and delivery units was only 2%, which was not a major disruption in terms of their workflow. So this study, I think, is really important because it provides the strongest evidence to date supporting the use of early warning trigger tools. It's important to note, however, these trigger tools were also tied to clinical protocols for the management of most common causes of maternal morbidity. So really, you want to think about introducing these two interventions together. So an early warning trigger tool and coupling that with protocols to manage these complications. So early warning trigger systems are based on vital signs that are going to detect acute deterioration of patients. They're going to detect patients that are having complications occur once those complications have started to occur. And the notion is, again, that they identify these patients fairly early in their course. But it's also important to make practitioners on labor and delivery units aware of the risks associated with patients' obstetrical and medical conditions. And if we can identify high-risk patients ahead of time, at the time that they're admitted to labor and delivery units, or even prior to their admission to labor and delivery units. It allows a thoughtful deployment of resources. It allows us to think about our nursing ratios. It identifies patients that are at high risk for heightened surveillance. So we can pay really close attention to the patients that have the highest risk of maternal morbidity. It allows preparations to be made for delivery, thinking who's available to provide care for these patients from both an obstetrical team perspective as well as the anesthesia team perspective, and backup plans if the patient did have a complication. And then finally, if we can identify really high-risk patients ahead of time, it allows us to determine their appropriateness for a certain center for delivery. So if patients are very high risk, it may be that they're best delivered at a high-risk tertiary care center rather than a small community hospital where resources are more limited. So our group back in 2013 developed an obstetrical comorbidity index for use in patients who are being admitted for labor and delivery. And this was really designed as a tool to be used for health services and epidemiologic studies. We used a large database of over 800,000 pregnancies where the rate of occurrence of severe maternal morbidity was 1.2%. And then we defined 20 maternal conditions that may be associated with maternal morbidity and then scored them based on the strength of the association with severe morbidity, and then summed all of the points associated with each of the maternal conditions into a single score that we term the obstetric comorbidity index. And I'll explain further what I mean in the next slide. So this was our logistic regression model predicting severe maternal morbidity in our database. We generated, these are all of the conditions that we considered. You can see 20 conditions plus maternal age grouped into 3 categories, greater than, or excuse me, 35 to 39 years old, 40 to 44, or older than 44. And then we generated beta coefficients, which is a statistical measure that looks at the independent strength of association with each of the conditions with maternal morbidity. And then based on the beta coefficients, we assigned a weight to each of the conditions that were considered. And the weights ranged from 1 to 5. Women with severe preeclampsia or eclampsia received a weight of 5, chronic congestive heart failure weight of 5, where in contrast, the patient that had asthma or pre-existing diabetes would have a 1. And so the way you calculate a patient's OBCMI is you look for whether they have any of these conditions, you mark which conditions they have, and then you assign or you add up all of the weights associated with all of the conditions that the patient has, and that creates a single score that's assigned to the patient, their OBCMI. So this tool was originally developed as a way of summarizing risk and adjusting risk in a research setting. But a few years ago, one of the obstetricians and I had the idea that we could use this in clinical practice. And so we implemented it at the Brigham as part of a quality improvement project, a initiative where a patient's OBCMI was calculated for all patients on admission to labor and delivery by the labor nurse, and then it was updated at change of shift if there were any new maternal conditions that were identified. If the patient had a score of greater than 6, which corresponds to quite a high risk of maternal morbidity, the responding clinician is notified, and so that they can ensure that an appropriate plan for the management of the patient's in place. And then when we have our multidisciplinary rounds twice a day, the nurse that's caring for the patient reports the score and the basis for the score. So they'll say Mrs. Smith has a score of 6 because she has severe preeclampsia and asthma. And this really heightens everyone's awareness of the patients that are at highest risk who are on the labor floor, but it also alerts the team to the conditions that underlie the single summary score. It allows us to make sure those conditions are acknowledged and being effectively managed. So this just shows the scoring system that we used. It was on a paper scoring system when we originally conducted the study and implemented the project. We now have it built into our electronic medical record, and it's calculated in a largely automated fashion. And these are the data that show the association between the use of or between the patient's obstetric comorbidity score and their risk of severe maternal morbidity. So these are cases of severe maternal morbidity that were adjudicated based on chart review. They represent quite severe adverse outcomes. So patients that were transfused 4 or more units, many other were hypoxic, went to the ICU, that type of morbidity. And you can see that patients who had a score of 0 had a less than 0.5% chance of having one of these severe morbidity outcomes. In contrast, patients that had a score of 9 or greater, the risk of one of these severe morbidity outcomes was nearly 1 in 5. So the score is well calibrated. The C statistic was 0.8, which is a very high statistic. It indicates really strong discrimination. That the tool is really effective at differentiating patients who are at high risk compared to those who are not. So this tool has now been, as I mentioned, deployed across all of the Mass General Brigham hospitals, the health system that includes all of the Harvard hospitals. It's been deployed at the Cleveland Clinic, many other institutions around the US. And it's really, I think, a very helpful tool at identifying patients who need extra attention to make sure we have good plans in place for patients' care. So the take-home messages from the talk. Well, we talked about how early warning systems can help identify patients at heightened risk for deterioration. These systems are created to identify the kinds of complications that are the leading causes of maternal morbidity and mortality. It's designed to help avoid the dual trap of denial and delays that we know underlie many of the cases of preventable maternal morbidity and even mortality. And we reviewed data from Larry Shields and colleagues that suggest that when tied to clinical protocols, the use of early warning tools can decrease maternal morbidity, that it can really affect maternal outcomes. And I think this data really provides a very strong motivation for the routine use of these tools on our labor and delivery units. And then finally, I described a novel risk stratification tool, the OBCMI, that we've developed and which we use in routine practice at our hospital, and described how it may provide a helpful way to identify patients with high-risk conditions. So thank you again very much for having me at this meeting. I'd welcome any questions during the question and answer session later in the session.
Thank you very much. There are some questions. A couple of questions we can take right away.
Okay, excellent.
One of them pertains to endpoint of resuscitation in witnessed maternal hemorrhage. How would you go about it?
So the question is, what types of endpoints would we follow if we're resuscitating a patient for obstetrical hemorrhage? So that's I think it's going to be highly context specific. It's not an easy thing to give a single short response to. I mean, obviously, you're going to be following labs, you're going to be following the patient's vital signs, you're going to be following, if you have an arterial line, you're going to be following signs of hypovolemia and respiratory variation. And so it's, I think you have to take into account the entire clinical picture and the severity of hemorrhage, the estimate of blood loss. All of those things are going to inform the way you manage the resuscitation.
I think probably the delegate would be, interested in knowing, are you people doing point of care testing? And do you also see over transfusions? Like sometimes you do not know how much blood to transfuse. You're going by your hemoglobin, and then when you're giving colloids and a lot of crystalloids, you see sometimes like you over transfuse too. So do you see over transfusions in your setup also?
I would say far more often than over transfusion. I think people get into trouble from under transfusion. I think can you overshoot? I mean, a bit and have a patient after a hemorrhage that has a crit of 32? Yeah, sure. Sometimes it's hard to get the resuscitation just right, but I think in general, I would rather over transfuse and have the patient have a slightly higher crit than what we would ideally aim for than to under resuscitate. I think under resuscitation is where most of the bad outcomes happen. In terms of point of care, we have a ROTEM machine available in our labor and delivery unit that we will use in cases of severe hemorrhage. We don't have point of care hemoglobin testing. We're fortunate to have a lab that is able to turn that test around quite rapidly in 10 or 15 minutes. But I think, in the right care setting, a point of care hemoglobin measure might be quite useful.
Thank you very much. There's one more question which we can take. We have 1 minute to go. That is regarding the comorbidity index. So there have been queries like comorbidity index is a new score. Are you also trying to develop something which is very simple and like a bedside tool, like QSOFA score? Because this is like it's got a list of things to see. And how does it, differ from Muse? Or
yeah. So that's an important.
Or Muse to be implemented to this. Once you say this comorbidity index is more than 6, so now you need to implement Muse on these women. Is that it?
Yeah, it's an excellent question, and it's actually an area of ongoing research. So we talked about the Muse systems where they trigger based on vital signs, and then the comorbidity index is really looking at maternal conditions, not vital signs, not physiologic derangements, but maternal conditions that confer a higher degree of risk. What we're trying to do is look at whether the vital sign thresholds that should trigger a Muse alarm may be different in patients that have high CMIs compared to low CMIs, and whether there's ways of improving the specificity and the false trigger rate and the performance characteristics of the Muse tool if we tie it to the CMI. So I think that's a very interesting area for future research, whether we can individualize the Muse vital signs thresholds and have thresholds that are more sensitive in patients that have high-risk conditions.
I think the dynamics of pregnant women are very fluctuating. So probably Muse, when you go further, I don't know, maybe Muse is going to play a role in comorbidity index more than 6. That's what we take back home today.
I think that would be a very reasonable takeaway. That if patients have a high comorbidity index and you use the comorbidity index in your practice, if patients that have a high CMI trigger a Muse, you should definitely pay very close attention, because it's a group where the risk of having a severe morbidity event is very high. Again, there's still data or research underway to sort out exactly what the threshold should look like at different score levels, but I do think that's a reasonable interpretation as to how the two tools can be combined.
Thank you very much for addressing a very important topic. We would love to have you still in our speakers gallery, and if you're there and there's some questions popping in, then I may ask you. Is that okay with you?
Absolutely. Thank you so much again for having me.
Thank you. So we move on to our next lecture. So the next lecture is going to be delivered by Dr. Lisa Leffert. Lisa Leffert is Vice Chair, Faculty Development and Chief Division of Obstetric Anesthesia at Boston, USA. She's a past president of SOAP. She's the section editor of obstetrical anesthesia in Current Anesthesiology Reports and Journal of Clinical Anesthesia. And she holds the position of associate editor in regional anesthesia and pain medicine. Lisa Leffert has a lot of work done in preeclampsia, and all the delegates who are interested in knowing more about preeclampsia must Google her name and find the publications under her name. So today also, she's going to address us on preeclampsia the anesthesiologist's perspective. Over to you, Dr. Lisa.
So it's a pleasure to be here today to talk about preeclampsia from the anesthesiologist's perspective at this important conference. Now, preeclampsia is a very large topic that in and of itself could take an entire conference, and we have but a short time together. So as such, I'm going to give more of an overview, and I've left my email at the bottom of this slide and the last so that you can contact me if you'd like to discuss anything in more detail. I'm going to start with talking about the epidemiology and the outcomes, and then focus on some of the tools for the anesthesiologist. Preeclampsia affects 5 to 7% of the population worldwide. It's a major cause, if not the major cause, of maternal morbidity and mortality, depending on where you are. 70,000 maternal deaths and over 500,000 fetal deaths. And the precise etiology is unknown, although there is a lot of work being done to try to elucidate what it is. The definition of preeclampsia has evolved. In the United States, starting in about 2013, there were some important changes. And that was that although proteinuria is still part of the definition, there was an important move to not delay the diagnosis of preeclampsia, to wait to demonstrate proteinuria, number one. And number two, the distinction between mild and severe preeclampsia was changed so that you have preeclampsia as your disease. And if you have evidence of end organ dysfunction, you have preeclampsia with severe features. The very next year, the International Society for the Study of Hypertension within Pregnancy moved to a very similar definition. The risk factors for preeclampsia are vast, with a relative risk, if you have prior preeclampsia, of over 8. Chronic hypertension, prior diabetes, multiple gestations, and obesity also put you at increased risk. And there are other risk factors, which include autoimmune disease, history of stillbirth, prior placental eruption, and even assisted reproductive technologies. And I haven't even mentioned them all. Whereas we don't know the precise etiology and pathophysiology of preeclampsia, there has been a lot of work done. And I thought this particular schematic from a Circulation Research article in 2019 with some of the most important researchers in the field was extremely helpful. It basically breaks up the pathophysiology into 2 stages. The first is there's no preeclampsia without a placenta. And whereas usually you have the trophoblasts of the placenta doing deep invasion into the maternal myometrium, making those maternal spinal arteries very wide and low resistance, high flow vessels, there's abnormal placentation in preeclampsia with superficial invasion. And these vessels look more like atherosclerotic vessels. And in fact, they get plaque, just like atherosclerosis. And what combination of genetic factors and maternal environmental factors and immunologic factors lead to this is not 100% clear. But what is clear is there's placental ischemia, persistent hypoxia, and oxidative stress. And this leads to an increased amount of circulating anti-angiogenic factors, just what you don't want. And we are well familiar with SFLT and circulating endoglin, which are 2 of the most important and detrimental factors. And all of this leads together to systemic vascular dysfunction and the kind of end organ disease signs and symptoms that we're used to thinking of. At the endothelial level, if we look to the right, what we see is these circulating factors actually interfere with other really important factors, growth factors like VEGF and such, that are really important for endothelial relaxation. And that also leads to a lot of the pathology that we see. These are targets for therapy for preeclampsia, both plasma apheresis, removal of some of these anti-angiogenic factors, monoclonal antibodies,
gene silencing, and some of the most interesting research, repurposed drugs, things like metformin, sulfasalazine, and pravastatin, which is particularly hot right now. But ultimately, the cure for preeclampsia is delivery. It's really important to diagnose preeclampsia, and it's really important to diagnose it accurately. The ASPIRE trial was a very ambitious trial, 27,000 patients, all with early-term preeclampsia, which we'll define in a moment. And it had two major purposes. One was to see whether low-dose aspirin started in the first trimester and continued to the third trimester would reduce the incidence of preterm preeclampsia. And it did, the one thing that has shown to do so. But the other was to look at a somewhat novel screening mechanism. And it's important to know who does have preeclampsia to try to avoid the end organ damage, and also who doesn't to try to avoid unnecessary delivery. And this was a pretty nifty calculator that looked at markers that include maternal arterial pressure, uterine artery pulsatility index, and some of these anti-angiogenic factors. And this screening test performed very well. There's also a promising screening method in use during the third trimester using combined biomarkers such as the ones that we looked at with a high sensitivity and specificity. But none of these are to the market, widely used at this point. There are also recent studies that show that these screening methods are worth doing because they reduce the false positive rates of diagnosis, unnecessary hospitalizations, and it's economical ultimately. So we talked about preterm preeclampsia. Let's define it. Preterm preeclampsia presents at 20 to 37 weeks. Approximately 0.3% of women in developed countries have it. So it's a small percentage of women, but it's increasing. It's often the more severe of the preeclampsias. If you're looking for a single test, Doppler velocimetry is the best. And the risk-benefit of morbidity with and without delivery is really tested here because the babies are so preterm. Therapy includes antihypertensive agents, steroids for lung maturation, and magnesium for neuroprotection. Observational studies have shown that expectant management can actually prolong pregnancy a week or slightly more. And the ACOG, which is our U.S. obstetric organization, guidelines are that by 34 weeks, if you can get there, delivery is indicated. And if you don't have severe features, you can wait till 37 weeks. Term gestation, anything over 37 weeks, preeclampsia that manifests, delivery is recommended soon after presentation, although it does not have to be a cesarean delivery. There's no role for antenatal steroids, and then the IV magnesium is more to raise the seizure threshold. It's important to note here that up to 50% of women who develop preeclampsia are actually diagnosed in the postpartum period. The deaths often happen here and often once the patient is home. So it's incredibly important to follow these patients. There are very dire short and long-term outcomes, both for the mother and the fetus of preeclampsia. We're used to thinking of some of the obstetric ones, abruption, intrauterine growth retardation, preterm delivery, and postpartum hemorrhage. But there are also things like venous thromboembolism, both hemorrhagic and ischemic stroke, up to 5 times greater in these patients. We're going to talk about acute pulmonary edema, renal failure, up to 5 times greater, and postpartum cardiomyopathy. There's some interplay between the anti-angiogenic factors in PPCM and preeclampsia, and the link is not totally understood. For the fetal short-term outcomes, increased incidence of bronchopulmonary dysplasia, and for reasons that we don't totally understand, decreased incidence of retinopathy of prematurity. These long-term maternal outcomes are striking. some of these studies have followed women for over 30 years. And not only do they have hypertension and coronary artery disease and congestive heart failure, but death from myocardial infarction, the hazard ratios are significantly increased, meaningfully clinically increased, and not just preeclampsia, but even just gestational hypertension. End-stage renal disease we talked about, and even cerebrovascular disease, vascular dementia and death. And I just recently reviewed a paper on cognitive decline. And there are long-term outcomes for the child and even into the teenage years, increased risk of cardiovascular disease and pulmonary hypertension. Some of the most difficult things about women with preeclampsia are actually managing them and managing their fluid status as they are intravascularly dry and as extravascularly overloaded. And fortunately, we as anesthesiologists have become very good using point-of-care ultrasound, or POCUS, if we are fortunate enough to have these machines with us to learn. So let's talk about the role of point-of-care ultrasound in treating preeclampsia. Cardiac ultrasound is probably the most familiar to us. Pilot studies of POCUS in preeclampsia reveal pulmonary interstitial edema, cerebral edema, and cardiac dysfunction, as well as correlation with increased peptide, abnormal brain natriuretic peptide, or as we are used to calling it, BNP. Specifically focusing on cardiac, preeclampsia is associated with maternal cardiac remodeling and diastolic dysfunction. And you can even get down to the level of looking and seeing the differences between early onset and late onset preeclampsia and how that looks different from controls, women without preeclampsia. And this one study looked at the prevalence of concentric hypertrophy and diastolic dysfunction, and it was highest in the early onset, then in the late onset, and lowest in the controls. And by the way, BNP was significantly higher in the same order as well, normal in the controls. Lung ultrasound for these patients has been getting a lot of attention, and I'll spend a few minutes on that. We take advantage of some artifacts in lung ultrasound, and those are called A lines and B lines. And I show you here, obviously on a man, where the probe is placed for lung ultrasound. So here we have an enlargement of the pleural line. On the left, we see the A-line artifacts. And on the right, we see the pathologic B-line artifacts. The characteristics of these B lines are that they arise from the pleural lines. They are hyperechoic. They're quite well defined. They extend indefinitely down, erasing the A lines. And if there is lung sliding on lung ultrasound, they move in concert with the lung sliding. So here are two studies which essentially show the same thing in terms of lung ultrasound predicting interstitial edema in patients with severe preeclampsia. And often these studies use both cardiac and lung ultrasound. This was a prospective cohort study, small studies, both of these 20 parturients with severe preeclampsia and 20 healthy controls. The goal was to assess the ability of lung ultrasound to detect pulmonary edema and to highlight relationship between these B lines and increased left ventricular and diastolic pressure, indicating pulmonary edema or failure. And these lung and cardiac ultrasounds were performed before and after delivery, and pulmonary edema was determined using two scores on lung ultrasound, and the specific scores are less important, something called the B pattern and something called an echo comet score, which is looking at B lines in multiple areas of the chest. And LVEDP was assessed using TTE. And basically the results were, in a quarter of the patients with severe preeclampsia, lung ultrasound detected interstitial edema. It also, these B lines were associated with increased LVEDP, as shown by the mitral valve E/E ratio, and a high echo Comet score predicted increased filling pressures with a pretty good sensitivity and specificity. And this led the authors to conclude that lung ultrasound detects both pulmonary edema and increased LVEDP in severe preeclampsia, and that this finding of these B lines should make a clinician consider restricting fluid, but of course that this was a small study. So this is another small study a few years later. Again, prospective cohort study, 21 severe preeclamptics, 12 healthy patients, again, to evaluate lung and cardiac function for the assessment of fluid tolerance or responsiveness in pre and post delivery. Again, lung ultrasound looking at, and cardiac looking at very similar scores. And what they found was severe preeclampsia was associated with increased extravascular lung volume. And these were able to be discerned prior to the patients having symptoms. And if you want to see what the actual data looked like, here it is on the right. This is specifically looking at the box and whisker plot of that echo Comet score that adds up B lines in lots of places, lots of regions of the lung. And what we see is the first box and whisker score on the left, in the severe preeclamptic on the left, and the right, the control, is statistically significantly higher in the severe preeclamptic. That's pre-delivery. The second is 1 day post-delivery. And by 4 days post-delivery, the patients are indistinguishable. And more lung ultrasound and preeclampsia studies registered to go. Ocular ultrasound is something that has been used in traumatic brain injury for quite some time. This is a picture of what ocular ultrasound looks like being done. And this is a picture in the bottom of what the actual ultrasound picture looks like. And ONSD, we'll talk about in a minute, is the measure that we're most interested in. I'm showing you one of multiple studies, ocular ultrasound for diagnosing increased intracranial pressure in patients with severe preeclampsia. This was a prospective observational study, again, small numbers, 30 patients with severe preeclampsia, 30 healthy. And this ONSD, optic nerve sheath diameter, which you saw pictured, measured 3 millimeters behind the globe, as well as another measurement, optic disc height. Again, were compared pre-delivery 1 and 4 days post-delivery, just like we saw with the lung ultrasound, and they were different in the preeclamptics. At 1 and 4 days, at 1 and pre-delivery, excuse me, but not at 4 days. And the conclusion was severe preeclampsia was associated significantly with higher values in both of these, and that this in turn was consistent with papilledema and cerebral edema. Now, what's the relevance of this? This sounds very, very scary. Well, in a couple of case reports, this was actually associated with vision loss in patients. And when seen, it actually helps steer people to the diagnosis of preeclampsia. This has also been suggested as a use for a measure of fluid overload, although there's some concern that once dilated, this optic nerve sheath diameter would not return to normal as quickly as, for example, lung water would be absorbed. Although in the one study we looked at, it was back to normal by 4 days. This is the most important take-home message when you read these particular studies. The presence of cerebral edema on these scans does not mean that these patients are not eligible for neuraxial anesthesia. This is not the kind of cerebral edema or intracranial hypertension that means the patients are going to herniate. The details of that are a talk in and of themselves, and we can talk about them in the question and answer period. But there is no pressure differential. There is no increased risk of herniation unless something else is going on. So what about our anesthetics? It's been known since 1982 and before that lumbar epidural analgesia improves the intervillous blood flow during labor in severe preeclampsia. So go labor, neuraxial labor, epidurals, CSCs, and spinals for labor. And in fact, in our American Society of Anesthesia, they strongly agree, and our SOAP and all of the other societies and yours as well, we strongly agree that early insertion of a neuraxial catheter for preeclampsia helps reduce the need for GA if an emergent procedure becomes necessary. And among other things, it decreases circulating catechols. This is some information a little bit hot off the press. One of the things that people worry about with preeclampsia is the patient going to be thrombocytopenic? Is the patient going to be coagulopathic? And is that going to interfere with my ability to do a neuraxial anesthetic? And let me tell you two things. One is that there's some recent retrospective evidence that platelet counts less than 100,000 in preeclamptic patients, not HELLP syndrome patients, but preeclamptic patients, is actually incredibly rare. And drops in platelet counts over the 72 hours, if they don't have HELLPs, are even rarer. Secondly, we are coming out, SOAP and a group of other multidisciplinary associations is coming out with recommendations for neuraxial and thrombocytopenia. And we thought we might have different recommendations if the patient had thrombocytopenia and preeclampsia, but we don't. And our recommendations are that 70,000 and above, the evidence that we have are the risk of spinal epidural hematoma, and with the data we have, is very low. The patients that you worry about are the patients with rapidly dropping platelet counts, like the HELLP syndrome patients, and those are the patients where you want to get that epidural in while the platelet count is still above 70,000 and not pull it out until the platelet count recovers. So what about cesarean delivery? There are so many different studies from all over the world we're going to see about cesarean delivery. For a long time, we worried that if we did a spinal in a patient with a severe preeclampsia, that we would drop their pressure. But in fact, the sympathetic nerve activity is actually elevated in a patient with preeclampsia over a normal pregnant patient and a hypertensive non-pregnant control. And there's reduced baroreflex sensitivity and greater antihypertensive response. So our medications actually work. And the incidence of hypotension after spinal was actually less frequent in a preeclamptic versus a normotensive pregnant woman. It turns out, although we love phenylephrine, a recent study shows that you can use either phenylephrine or ephedrine to treat our preeclamptic patients undergoing cesarean delivery. So what about spinal versus epidural for cesarean delivery? This was one of the early prospective randomized studies. It looked at patients with spinal and epidural and a meaningful mean arterial pressure difference of 10, very reasonable doses for both. And it showed that whereas the incidence of hypotension was a little bit different, and the use of ephedrine was a little bit more in the spinal group, the duration was short and the adverse outcomes were small, not even in the setting of hypotension. And the beauty of spinal for cesarean delivery has been shown all over the world. And that general anesthetic babies tend to do worse, sometimes because they started out worse in the first place. Most of these studies are not randomized controlled studies. Most of these studies are retrospective studies. So oftentimes the babies that end up with general anesthesia are the babies that are having more urgent situations in the first place. But nothing shows us that general anesthesia is better in preeclampsia. And this study which is a secondary analysis of a very large prospective observational cohort study that looked at spinal, CSE, and epidural anesthetic. There are a lot of words on this page, but ultimately what it shows is that spinal may be associated with less short-term fetal morbidity in preeclampsia undergoing cesarean delivery. If you are going to do a general anesthetic, it's extremely important to use adjunct agents. And I highly recommend this anesthesia and analgesia article, which will tell you about all of the different adjunct agents for induction and the doses that you might use. And this relatively new article that has come out talks about dexmedetomidine as part of induction and fetal outcomes. And it basically showed that 2 different doses of dexmedetomidine, an initial bolus and an infusion, were associated with hemodynamic and hormonal stability without evidence of adverse neonatal outcomes in general anesthetics. There's some evidence that women with preeclampsia experience less pain, but absolutely use NSAIDs as part of multimodal analgesia. There are 2 important studies, which I show you here, and I won't go into in detail, that show that there was no evidence of increased hypertension or more refractory hypertension in preeclamptic patients who got non-steroidal medications. So in summary, the clinical pearls: multidisciplinary team management is ideal, combining maternal risk factors, serum biomarkers, urinary Doppler has the highest predictive value for preeclampsia. Use POCUS if it's at your availability and your techniques. And Neuraxial is safe and typically preferable to general anesthesia. If you use general anesthesia, use adjuncts to minimize hypertension, and don't forget about NSAIDs. Thank you so very much. I look forward to your questions.
Thank you very much, Dr. Lisa. That was an outstanding review of evidence in a clinical entity, which always keeps us on our toes. So I have some questions very quickly. We can go about it because we're a little short on time. Questions are pertaining mostly to POCUS in preeclampsia. There is a query that B lines are associated with the preeclampsia. You have shown us. There's a diastolic dysfunction too. Do you also see systolic dysfunction?
Systolic function is less likely. I mean, the reality is you can see anything in preeclampsia. If you see significant systolic function, you should probably also begin to think if there is something else going on, like peripartum cardiomyopathy. So I would never say never about anything and preeclampsia, but if there is marked systolic function, dysfunction in a preeclamptic patient, you should also begin to see whether there are things like peripartum cardiomyopathy and other things going on, SCAD or heart disease in general.
So given that ultrasound is freely available on labor floors, would you give this piece of advice to our obstetric colleagues who are also in this audience? And the audience is now 1,700 plus at the moment. So would you also ask them to use as a handy tool, or would you like it to be in the hands of anesthetist, because that's the way it is?
Oh my gosh, I don't think there's a right politically correct answer to that. What I would say is that we are at our best when we are working together, and it is clear that both anesthesiologists and obstetricians have excellent ultrasound skills. So if together we can complete the world of different ways that we can use POCUS to really help obstetric patients, particularly without interventional and invasive monitoring, we are doing our best as a team.
Okay, there's another one on optic nerve sheath diameter. The delegate is asking, is there any cutoff value for optic nerve sheath diameter in preeclamptics? And does magnesium sulfate treated preeclamptics have any benefit in terms of decrease in optic nerve sheath diameter in these women?
So for the second question, that is a great study, and you must do that. That is a really interesting question, and I have not seen the answers to that study in terms of magnesium and changing the optic nerve sheath diameter. There are technical cutoffs as to what qualifies as increased ONSD. We are not, I don't think, at the point of being so clear about being able to look at ONSD and saying that person has preeclampsia and that doesn't. It's much more at the level of saying, this is what ONSD looks like in preeclampsia. So more to come with more studies to understand it.
One last question. Since you spoke about non-steroidals as being a useful drug, and especially in opioid epidemic, one person has said that there was one study to suggest that preeclamptics suffer less pain because they also receive magnesium sulfate. So is that the cause, or that is why we should opt for it? Do you believe in this theory?
Oh, so thank you for making that suggestion. So there is a study, just like they said, that said that because patients are on magnesium, they suffer less pain. That said, it is clear that preeclamptic women need postpartum analgesia. They need intrapartum analgesia and postpartum analgesia. And if in fact there's a little bit less pain because of magnesium, clinically, that's not necessarily manifest. For a while, people were withholding one of our most important pain management tools, which is nonsteroidals, from these women because they were worried about their hypertension. And they were using studies outside of obstetrics to invoke as reasons to do that. And that's why I brought up those two studies, to say the studies within obstetric patients do not support withholding nonsteroidals. So just as you said, nonsteroidals are very important for opioid sparing, and the studies within the obstetric population do not support withholding nonsteroidals or any other ones of our analgesics for preeclamptic patients. So use analgesics for preeclamptics. It's an interesting scientific question as to whether magnesium decreases the pain that they suffer, but they still need analgesics, and use what we use.
Thank you very much. There are a couple of more questions. If you are there at the end of the day, then maybe we will take up those. Thank you for being with us and giving us this excellent talk on preeclampsia, anesthesiologist perspective. So we move on to another very important topic, which we call as twinning with our obstetric colleagues, because placenta accreta remains a very, very daunting task at both ends, at the obstetrician's end as well as the anesthesiologist end. So here we have paired up with our team on this topic. We have Dr. Ozhan M. Turan, who will be speaking first from the obstetrics point of view, followed by Dr. Shobna Bharadwaj. And to introduce Dr. Turan, he is Director of Fetal Therapy and Complex Obstetric Surgery, and is a professor in obstetrics, gynecology, and reproductive sciences at University of Maryland School of Medicine, Baltimore. He received his fellowship and training in maternal and fetal medicine at University of Maryland Medical Center, as well as in Harris Birthright Center in London. His areas of interest focus on preterm labor, obstetric surgeries that are high risk for complications, and fetal therapy, including laser and intrauterine interventions. So I welcome Dr. Turan to speak on placenta accreta spectrum, the obstetrician's perspective. Welcome, Dr. Turan.
Thank you very much for the nice introduction. Are you able to see my screen?
Yes, we can.
Good. So first of all, I would like to thank the organizing committee for the nice invitation. In 20 minutes, I will try to summarize what placenta accreta spectrum is and how we manage as a multidisciplinary team. And we're going to, I will try to give information about at Maryland how we do in our complex obstetric surgery program. I don't have any conflict interest. I want you to remember three things from this talk if you don't remember anything else. The one, the classification of placenta accreta spectrum is not perfect. Two, multidisciplinary discussions enhance the care. Three, standardized surgical technique improves outcomes. These are the specimens after the cesarean hysterectomy. I just want to orient you. This is the corpus when we deliver the baby from the top. This is the low uterine segment and placenta protruding out, and the cervix is here. This case ended up with a QBL quantitative blood loss of 1,380. This case is the same, but only 800. This case is almost 2.5 liters, and this case, 550 cc. So what is the difference? They look all bad, but some of them bleeds more, and we don't know who will bleed more. Is it the diagnosing problem? To overcome this hassle, FIGO published a new classification system I tried to summarize, simplify in this slide. In all diagnoses, we know that the accreta, increta, percreta. Now they divided them to three different categories to percretas, grade 3, A, B, and C. A means that placenta invading serosa, and pathologically, they found villi in the breaching serosa. In B, surgical plane between bladder and uterus, the villi, and pathologically, they can see villi in the bladder or uroepithelium. And C, placenta tissue invades other organs, and pathologically, villi in the pelvic organ and tissue. The aim of this new classification was to talk about what percreta, which percreta is the percreta. If it is, can we actually identify the blood loss or risk of complication by looking the categories? However, I just want to remind you, all these 4 cases that you have seen, all of them is grade 3B. Why multidisciplinary management? Everyone, you can see many articles about multidisciplinary care on placenta accreta spectrum. This is one of the best study. Therefore, I wanted to show you. This is a kind of setting. What they did, they look at the outcomes of one multidisciplinary care center and compare with a standard care center, which is a community hospital run by very experienced obstetric surgeons. If you look at the data, urgent and suspected cases, the risk of a reoperation in first 24 hours is about 36% in the standard care center, only 3% in multidisciplinary care center. And if you look just on the suspected cases, which means that everybody know what's coming and prepared them well, the blood loss is significantly low, early operation rate is low, and large blood volume transfusions is 70% versus 42%. And the risk reduction is about 78%. So yes, true, the multidisciplinary approach improves outcomes. What does it mean, multidisciplinary team, and who needs to be there? First, a diagnostic team we need, and could be a maternal fetal medicine physician, could be an obstetrician radiologist, needs to be able to reach MRI, ultrasound, 2 or 3D Dopplers. A surgical team. I called as a pelvic surgeon because in the reality, every obstetrician thinks that they can do hysterectomy. But this hysterectomy is different than the regular gynecologic hysterectomy. Therefore, somebody who knows pelvis well needs to do the procedures. It could be an MFM. I'm an MFM and I train for pelvic surgery. It could be a generalist, or in many places is a gynecologic oncologist. We need definitely need an obstetric anesthesia team who knows what acute blood loss can be identified and fixed. And the most important thing is All those things need to be done in a standardized way. Means that each time, each moment, each step needs to be equal. Because if anyone else do things is differently in each case, you cannot understand what the mistake is. However, if you use a standardized technique, it is easier to identify the mistakes or pitfalls and fix them. And you need some other services, some consultative surgical services, urology, trauma, vascular surgery, or interventional radiology. And of course, you have to have an ICU units for mother and baby. Blood bank is one of the most important component for this blood cases. How we do in University of Maryland School of Medicine. So we have an obstetric team, maternal fetal medicine, attending that's the case, including myself. This is one of the rare place in the United States that the surgery is done by MFMs, not GYN oncologists. We have a dedicated obstetric anesthesia team. As you see, there are two coordinators I listed here. One of them is complex obstetric surgery coordinator. One of them is an ND coordinator. These two people are very important. And the course coordinator's job is not only to schedule the patients or get the transfer or transport calls. There's also that she has a specific job in the OR. Means that she's a bridge between me as a surgeon and anesthesiologist. Because if I'm very busy and in a stress working in a stopping blood loss, and I might not hear what they say and anesthesia says, or we cannot communicate well, this person's job is identify blood loss immediately in every 15 minutes if there is no, if it's a blood loss is in an acceptable levels, or if it is a severe blood loss is updating me almost every second. You're in 150 cc, you're in 500 cc, you're in 1000 cc, do you want to do this? And communicate between anesthesia and us, then actually we can see the case as a team. For example, in these meetings, we create a kind of algorithms to deliver, how to deliver the babies when we need to end up the surgeries. And we create a kind of algorithm. If the cervix is long and there is not bleeding during the pregnancy, we wait until 36 plus weeks. But the cervix is short and also patient has more than 2 bleeding episodes, we generally deliver them after 32 weeks. Now I'm going to, as a surgeon, talk about a surgical management. We do all these 4 surgical interventions, but I want to talk about the cesarean hysterectomy, which we standardize ourselves in the last 6 years. And I'm going to present you 2 of our papers about the standardized technique. This is the small literature review for you. All these publications is actually published and show their results, and they're very proud of their results. And all these things demonstrates how dangerous disease is this. As you know, the transverse RBC percentage is about 42% to 65%. ICU admission rate is 28% to 60%. And the injury rate for bladder or ureter is pretty significant. Now, if we don't use our technique, which we developed at university, this is our results for the 25 case from our most recent publication. Our numbers is pretty much as similar as the literature. 68% transfers more than 4 unit. ICU admission rate is 12%, and reoperation rate is 8%. This is exactly the same as the published literature. Once we use our described surgical technique, that reduces significantly. The number of RBC used is 18%. More than 4 units is 18%. And there is no reoperation. There is no significant complication. And cystotomy rate drops to 2% only. When we look at the cumulative blood loss, which we very strictly count almost every drop and during OR, if we use our surgical technique, That's the cumulative blood loss median 1,124 cc compared to if you don't use that surgical technique, 3,500 cc. And number of blood transfusions is you see that the transfusion more than 4 units of RBC is only 18% compared to 68%. Transfusion more than 6 units of RBC, 4.5% versus 52%. And this is the diagrammatic demonstration of cumulative blood loss. So yes, if you use a dedicated surgical technique that's for these surgeries, these cases, then your result will be better. Is it related with the pathology? If this is accretive incretin versus percretive, there's a difference. When we look at that, still in a technique group, the blood loss is lower compared to non-technique group in incretas, also for percretas. So the technique doesn't really make any big difference if you use in the blood loss, even with the severe cases. And we look at the determinants of predicting more than 4 RBCs. And we look at the type of anesthesia, is the pathology, if the case is urgent or scheduled, and surgeon, that's definitely a big component, or the surgical technique. And we found that the only significant predictor is surgical technique. When we first described this technique, we also look at the reproducibility of the technique and how we can get this in a good time. And we proved that after the 5th case, this technique can be used and produce a similar result by anyone else. Right now in the United States, 3 fellows trained by me does the surgeries in different parts of the United States with the similar blood loss numbers. The technique we called as linear cutter vessel sealing system technique, LCVSS, and I'm going to show you the technique in next 5-10 minutes. There are 4 steps to make the surgical approach is a standardized technique. Step 1, hysterectomy using linear cutter. Linear cutter, GI staplers. I do lots of fetal surgeries to opening of uterus for fetal interventions. I used 4 boxing stitches to reduce the bleeding, make a hysterectomy using electrocautery, and then put GI staplers and open the uterus. And it looks like, as you see, this it's closed, all the edges, and doesn't bleed. As published before, the blood loss from hysterectomy is only about 400 or 500 cc, even if you do a quick whip stitch. So it's not because of this depiction, it's not bleeding, but it's really not bleeding. As you see from this live pictures, this is the edge of the staplers, and it's not bleeding. And this is the edge of the staplers, it's not bleeding. The second step is do not manipulate the placenta. This is a very well-known entity for all over the world. Everyone knows that if this is a hysterectomy and if you pull the placenta, you increase your bleeding. Therefore, if this is an accreta, don't touch the placenta even gently and do the hysterectomy, which will reduce your blood loss. The third step is cauterization of vascular anastomosis using handheld vessel sealing system. I said handheld vessel sealing system, but at the early days, I was using only bipolar and the medicine bound, and I got the similar results if you don't have that opportunity. So in this depiction, you see that the loss of blood vessels is develops from placenta because of vascular factors, and all of them are actually connected each other in this area, which is very difficult to find out which vessel comes and goes to where. This is an example. As you see, there is a large anastomosis and big blood vessels. I want to show you one specific thing when the clip comes to first. I want you to focus on here. This is a large ovarian to uterine artery anastomosis. As you see, it's pulsating. And similar, and bladder comes until here, and we need to dissect from there to down. That technique, our surgical technique, helps us dissect bladder from here because most of the time the bleeding starts from here And once it starts bleeding, you cannot find your plane anymore. And then you have to do some quick things to stop, and then it bleeds more and bleeds more. So the technique demonstrates in this picture. We open the leaflet area and find each blood vessel one by one and grasp them, burn them, and cut them. You can use this vessel sealing system, or you can use only bipolar and the medicine-bound scissor. And this is from our first publication. As you see, the device in dissection and cutting. And I want to show you how we do this in a live patient. As you see here, this is the device, grasp them, burn, and cut, and continue this dissection until you reach the vagina without doing anything else, not clamping any big blood vessels. The fourth step is completion of bladder dissection until the cervicovaginal junction before ligation and division of uterine arteries. You see in this picture, after the hysterectomy, the uterus is removed. This is the vaginal cuff. And I want you to concentrate on these black marks. These are the burning points. And this is the whole blood vessels. All of them is engorged, large, and ready to bleed. Now we're going to go back 5 minutes prior, just before the clamping uterine arteries. Do you see the same blood vessels, but they're not as engorged as the here. Why? Because if you close these blood vessels here, then the remaining collaterals continue to push the same amount of blood, comes from the same branch to everywhere again. Then you increase the pressure in this segment, and you actually engorge blood vessels. Even sometimes after, if you don't complete your dissection properly, these blood vessels who are waiting for you is sometimes spontaneous eruption and bleeds. Therefore, we halt the uterine arteries after, or main blood vessels after completion of the whole dissection. When we started, whenever I give you this talk in another institution or another country, I always ask me how did we started and how did we improve our complex obstetric surgery program. So this slides from one of my earliest slides for introduction of complex obstetric surgery program. First, what we did is we identified the risk population, and we define as placenta-critical spectrum, previa. We have lots of obese patients, particularly weight over 350 pounds. Increased morbidity is based on previous surgeries, etc. Then in the multidisciplinary team meetings, we identified the individual risk. What is her obstetric risk, anesthesia risk, operative risk? And then we create a kind of management plan and put them into our electronic medical record for elective cases and urgent conditions. And when the patient comes to LND or bleeding or another reason, everyone knows what needs to be done, what kind of incision needs to be done, what kind of anesthesia, which lines we need to put in those cases. And our aim was, when we developed this program, is, of course, increase the care, pre, per, and post-operative, participate regional, national, international research, and continuous education and training of medical providers, and which we are providing all our aims. Then our number of patients and the cases is increased as 2015. We use in United States fiscal years, means that July 1st of one year to the end of June of other year. So our numbers were strikingly increased in over the time because we're doing a good job. In addition, there are big improvements in our cases. For example, the percentage of referrals to us with this program is about only 50% at the beginning. Now, right now, all these cases, all those increased. Only 3% is our cohort. The remaining comes from the referrals. At the beginning, we were placing everyone almost central line. Right now, we don't place any central line. Our obstetric anesthesia team improve themselves and use different techniques. And now you're going to hear from Dr. Parvash soon. And we don't use any almost central line. Regional anesthesia is almost always, we do regional anesthesia, and we don't go to OR anymore. This is how many components is actually used in our multidisciplinary team approach, from diagnosing to ultrasound unit to outpatient clinic to follow up to multidisciplinary meetings, surgery, and postoperative care. We also participate lots of research as well. Thank you very much for your attention. I'm happy to answer all these questions.
Yeah. Dr. Turan, I think we will finish with the other part of the, this lecture, because we have Dr. Shobna with us, and we can take the questions at the end because there are some questions, but we will finish this lecture all together. So is that okay?
Sure.
Okay. So next we will have Dr. Shobna Bhardwaj from the same university, Maryland University, working in the same setup. And she's the Obstetric Fellowship Program Director there. So Dr. Shobna is going to speak on the placenta accreta spectrum from the anesthesiologist perspective. So over to you, Dr. Shobna.
Thank you very much, Professor Jain. And we just, I'm just going to share the screen.
Yeah.
Just let me know if you are able to see. Are you able to see it?
We can see your desktop. So your point, yeah, there it comes. It's there now. Full screen?
Yeah.
Okay. Full screen.
I think it's just there's just black. So I'm going to talk to you all.
Yeah.
Are you able to see it?
Yes, perfectly fine.
It is full screen. I think there is a little time lag.
Yeah.
All right. So I'm going to talk to you all about the anesthesiologist role in the multidisciplinary management of these cases. And thanks to the AOA team for giving me the opportunity to talk about our practice. I have no conflict of interest, and I just have to disclose that I'm a part of the COS team that Dr. Turan mentioned. And I'm going to briefly talk to you all about the role of anesthesiologists in this whole collaboration, the pre-op, intra-op, and post-op considerations in these cases, and what we did prior to the technique that was developed by Dr. Turan and what we are currently doing now. And we all know that the anesthesiologist should not be functioning in a vacuum. And so a teamwork is very important. And one of the important members of the team is patient themselves. So we should focus on giving the patients very patient-centered care that would help with the delivery of a very safe and satisfying care. Unlike the obstetricians, we have very less contact time with these patients. So in the brief time, we have to get our skills to develop a rapport and reassure these patients. And typically, the antepartum consult helps in that case. And remember, we are also very good coordinators, so we should use those skills in coordinating these cases for a very smooth throughput, be it coordinating with the ICU team or the IR team or OR team, it doesn't matter, but coordinating these cases, it's very important. And we have to effectively, efficiently, and economically manage resources. Please know what you have and whom you have and how you can allocate the resources. And role designation, you have to be very cognizant of the team that you are working with and their skills. You're better off designating the roles for these blood runners and lab runners. Like Dr. Turan said, we have designated a cumulative blood loss calculator in the operating room and your anesthesia tech support because they play very important roles. And if you tell them what their role is and how important they are in saving mom and baby, they will understand. Especially I do this all the time when we do cases in the main OR. And I pull the blood runner and say that you are going to be saving life today. And it's very important that when we ask for blood, that you run and get it. And always have a contingency plan. And this typically starts like very early on during the multidisciplinary meeting. Always have a plan B. What if the patient comes in an emergency? What if the patient develops preeclampsia? So you always want to have a contingency plan, either in terms of where you want to do the procedure or how you're going to mobilize the procedures. So if you have a backup plan and when things happen, it's not chaotic. Continuous quality improvement. It's very important that we pay attention to what we do and how we do. And also, we have to be open for all feedback. And, some people learn from their own mistakes. Some people learn from others' mistakes. But the matter is like how much you learn and how much you are improving. So always every case is a teaching case for us, and always do a continuous quality improvement plan. And sorry about that. So moving on to the antenatal and pre-op considerations for these patients, when we typically see the patients during the antenatal period, when you see them, just focus on the comorbidities and initiate any kind of additional workup if you need. Some patients are obese, they need some echocardiogram. So whichever that you think that you need any additional workup so that we are not waiting at the last minute. You have to participate in all the multidisciplinary meetings so you know what the obstetric plan is and how things are evolving so that you can be prepared for that. Type in screening the patients ahead, especially many times these patients might have had bled the previous times, they would have gotten transfusion. So it's likely than the normal pregnant patients that they come with antibody positive screen. So if we know that information, we can make arrangements for them to come in early and get the blood cross-matched early on. And, definitely see what their baseline hematocrit is and treat their anemia. If you want to start them on PO iron or IV iron or even erythropoietin, especially in patients who are refusing blood products for religious reasons. And there's a great article in the Clinical OBGYN by Dr. Warwick and Collins on the anesthetic considerations for these cases. With the pre-anesthetic eval, it has to be thorough, including all the previous obstetric history, their anesthetic history, and not only moms, but also you want to know the baby's father's family history of MH. In case you choose to give inhalation agent or not. And, airway assessment is a big thing, and the ease of intravenous access in these patients to see how easy it will be to establish a peripheral IV access. Getting an informed consent in these patients is very important. And having the family in that conversation is also very important because many times these patients can end up in post-op ICU and mechanical ventilation so that the entire family knows what the expectations are. When you're consenting the patient, talk to them about fetal exposure to GA, the transfusion risk, and your risk of invasive lines, and how you manage the complications of those invasive lines. Those are things that the patients should know before they sign the paper. And, if you plan to convert to GA, the problems with the airway and, his recall, we know that, patients who have trauma surgery, cardiac surgery, those patients and C-sections, those patients are at risk for recall. And this is not a straightforward C-section. So you have to talk to them about definitely the possibility of post-op mechanical ventilation and any kind of truncal nerve blocks. And so baseline labs, you probably should be getting like a CBC, coagulation panel, fibrinogen to know where you're starting to, calculate your allowable blood loss and all that. And of course, you're going to go more clinically as well. and a comprehensive metabolic panel as baseline labs. And pre-medication just prior to the OR is with aspiration prophylaxis, regardless of the anesthetic that you're going to do. And, that includes a clear antacid, H2 blocker or and metoclopramide, and also getting ahead on your post-operative anesthesia, starting them on acetaminophen and gabapentins. If you are set up as doing enhanced recovery, then clear carb load, which is one thing that we do, could be done 2 hours prior to going into the OR. Okay, so coming to the type of anesthetic, there's always a debate between neuraxial or general anesthesia for these cases. When considering neuraxial, remember the patients are awake, which is good. They have the delivery experience. There's no fetal exposure to GA, but you may have to convert them to GA midway when the airway is all swollen from the fluid shift. But on the other side, when you have to choose general anesthesia, you remember you're having a control of the airway in a very controlled situation, and the patients are deeply anesthetized, they're comfortable, and they're comfortable for the invasive line placements. And but you do have to remember that there is a long induction to delivery time in these cases, which need a lot of prep before they even make a skin incision, especially cystoscopy, positioning, prep and drape, and all that. So, talking about the fetal exposure with the GA, last year at the SOAP, we submitted this abstract, on grant study that we call the general versus regional anesthesia neonatal outcome. We were looking at the ABGARs and the COT PH, and there wasn't much of a difference between GA and regional anesthesia cases. And remember, these are about mean of 40 minutes from the anesthesia start, be it a spinal dose, be it general anesthesia induction. And in any of those cases, with a long surgical, anesthesia start to delivery time, the outcomes were still favorable. So, which takes us to neuraxial or general anesthesia still remains the question. So if you're attending this part of the lecture to know which anesthesia is optimal, it is hard to say. I'm sorry to disappoint you, but let's look at the considerations that you want to do when you are choosing your anesthetic. Number one, what's the emergency? How emergent does the patient have to be delivered? Patient preference. Remember, we talked about patient-centered care. So patient preference, their comorbidities, and the degree and certainty of the invasion of the placenta. So you really don't want to overkill or underkill in your preparation, but I personally prefer being over-prepared if they are not certain about the extent of invasion. Provider preference, many of the OB anesthesiologists may be comfortable doing these cases under neuraxial anesthesia, but doesn't have to be the case with the generalist, when these cases are done elsewhere in the other operating rooms. And absolutely surgeon experience and skills. So what kind of surgeon you're working with and what are their skills, and that makes a huge difference. As we know, not with just this procedure, but with any procedure. And airway class, getting the airway, if you have a Mampati 4, do you want to get to the airway early on by doing a controlled GA instead of risking midway under the drape intubation? And I know your resource availability, it depends on how your practice setup is and what your logistics are. If all of that help you with the general anesthesia with a better outcome for mom and baby, and that's probably is what you should do. And be open for safe alternatives. Like our program, we started off with like 100% GA, and now we don't do GA at all. So it depends on how your performance is and how your practices and be open for all these safe alternatives. I just want to touch upon certain key points of whichever anesthetic that you choose. For the neuraxial anesthesia, it should be a CSE or CSA because spinal is not going to cut it because these are not like an hour procedures. They are at least 3 to 6 hours. And you really have to maintain T4 levels because you definitely need that peritoneal coverage when the surgeons have their hands deep in the belly. And also, if you saw that video that Dr. Turan showed, we use the Bookwalter retractors. And those retractions can get the patients uncomfortable if they are not adequately anesthetized to T4. And you have to aggressively treat the hypotension. Remember, your spinal dose to delivery times are prolonged. It's not like straight up C-sections. So you have to get aggressively managing the hypotension after spinal dose if you choose to do a CSE or CSA. And towards the end, watch for any local anesthetic if you do plan to use truncal blocks. If you have been maintaining the epidural with any kind of local anesthetic, and at the end, the regional anesthesia team drops in another 30 mL of local anesthetic, you really got to do your math and make sure that there is no local anesthetic toxicity from that block. And these patients are awake, so you have to be very good with your vocal anesthesia skills because you don't want to be sedating these patients too much, putting them at risk for aspiration. So vocal anesthesia is a major component for these cases under neuraxial alone. And then coming over to the neuraxial and general part, you have to know what is your hemodynamics during your rapid sequences. Are you planning to, is it a planned conversion to general, or are you just keeping the general conversion as a backup? So it makes a lot of difference because if you're probably planning, then you would soon after delivery convert to general anesthesia. But if you're keeping conversion to general as a backup, then you have to know and think about where you are starting a general anesthetic because you have to know the hemodynamics during rapid sequence induction. The patients are already hypovolemic, and you had to choose the right drugs, probably etomidate or ketamine. And also, there's a French study that, that showed that majority of the maternal deaths during this GA were when they were converted done at the time of induction is when the maternal deaths happen. And remember, you're putting the patient to the risk of 2 different anesthetic. Regardless of what your plan is, as a planned conversion or a backup conversion, you start the case with a very good position for intubation because you are intubating these patients under the drapes. Even without the drapes, you know how the intubation goes, but under the drapes, you really have to have them in a good, optimal position for intubation. Now, moving on to the general anesthesia alone, you have to optimize the induction and the rapid sequence induction. So you have to optimize the condition. And mainly, most importantly, is you have to maintain the maternal CO2 levels. Remember, the physiologic PCO2 is 28 to 34, so you don't want to go any more than that, and or any less than that. So remember, again, it's a long anesthesia start to delivery time. So plan on converting the anesthetic to a total intravenous anesthetic without using the inhalation agent after the baby comes out, so that the inhalation agent is not one of the reasons for uterine bleeding. And always there is a possibility of post-operative mechanical ventilation in these patients. So now, being prepared in the operating room, you want to have a dedicated team. It's not fair for the patient, and it's not fair for the provider to have, the provider have too many responsibilities. And so you have to have a dedicated team so that you're focused on that patient care. And get your IVs in, we typically do like an 18 plus a 16 or a 14. Or if you're not able to, then you have to do a central access arterial line. It's kind of a mandatory in these cases, I would say. And have the blood products ready in the OR. You know where your TXA and fibrinogen are, you know where your antifibrinolytics are, and also have the vasoactive drugs ready, you know, because that you may need them to remember you're using the vasoactive drugs in these bleeding patients just to temporize the blood pressure up until you catch up with the volume. We know that the blood loss can happen at the rate of 500 ml to 800 ml per minute, but you don't want to be treating the numbers on the screen with your vasoactive drugs. You just want to use them to temporize while you catch up with the volume. And definitely you have to use body warmers and rapid infuser and fluid warmers, because these are not 1 hour C-sections where you're in and out, you're in the OR. The patients do drop their temperatures, and you don't want them to drop their temperatures, you know, for various reasons. The main one being you don't want them to be coagulopathic. Rapid infuser, again, use the one that you're very comfortable with. You know, you may, you know, we do have these Thermocore, which like, you know, can get 1200 ml per minute, you know, or a Belmont, you know, or we have all those fancy. But personally, me, I'm more comfortable using the level 1. You know, in fact, one of the pat on my back cases was like a case where we, you know, had to transfuse 30 units of placenta paprika. But then the end of the case, my base deficit was 0. So, and all I did that was use the level 1. So, and of course, you had to be aware of air embolism in that. But again, use whatever you are comfortable with, but you do need a rapid infuser ready to go in these cases. Cell saver. There has been a debate about, like, you know, using cell saver for these patients. Again, you know, so far it looks like the safety margin is good. And initially we used to think that, you know, it causes, you know, AFE and DIC, but then with the addition of leukocyte depletion filter, it looks like we can use the cell saver to, you know, to salvage. But however, we still have to remember that all the bleeding that's intra-abdominal is good, but what about the bleeding that happens vaginally, you know? And these patients, if you have to retransfuse these vaginal bleeding, is that safe enough? I don't think we have data to say that it is very well, to say that it is definitely safe. So you may have to think about it. And again, during the case, it's a long procedure. You may have to redose the antibiotics. And again, remember, if you are more than 15 ml for blood loss, that's another reason that you may have to redose the antibiotics, and have a close look on the urine output, especially when there is a urethral injury, which is highly you know, possible in these kind of cases, and have accumulative blood loss. And again, the other thing is you have to, as an anesthesiologist, optimize the surgical condition. You have to help the surgeons operate, you know, either be it in terms of positioning or be it in terms of providing the patient optimal anesthetic. You don't want an awake patient moaning and groaning on the table when the surgeons are trying to operate. And also, you want to prevent any coagulopathies. I mean, just pull the slide from Dr. Turan's presentation, see how dry the field is. Remember, just seeing this, if the patient was coagulopathic, there will be all oozing, and you don't want to get into that vicious cycle. And again, periodic lab testing, you know, point of care, we talked about that with Dr. Bateman, and that should, you know, use all the resources that you have. in goal-directed transfusion. You do that only if the patient is stable. Transport with blood products and transport with pressors. And as Dr. Leffert talked about the focus, we are a lot into focus. If you have any hemodynamic instability, you look at ultrasound, look at the heart with the ultrasound. You know if the heart is underfilled or what is going on. And another growing interest is in the endovascular balloon occlusion of the aorta, for resuscitation. So Reboa has been used in a lot of cases these days, and there has been a couple of studies, but you do have to remember that it is not a benign procedure. It has to be done by skilled people. And also, there has been case reports of arterial thrombus, in these patients. So you have to think really hard before you jump into Reboa for all your cases. And now, when you're going out of the OR, the patient's post-op have to be monitored closely. And, are you going to extubate this patient or not? How are the hemodynamics? How do you think the airway is? Is it swollen? Are you going to take the patient to the ICU, or are you going to take the patient to the PACU? So all of this has to come at the end of the case, and you have to communicate all the plans. We do a heart stop at the end of each surgery. So you bring all that up in the heart stop and come up with a plan. And remember, if you're doing an uraxial, you have the epidural catheter. You don't want to be pulling the epidural catheter if you still have the patient on DIC, if their coagulation status is bad. So you may have to correct all that before you remove the epidural catheter. Now, all is that when, for the hysterectomy cases. But what about the interval hysterectomy cases where they, leave the placenta in and then bring the patient back in 6 weeks? Now, you may have to do a prolonged monitoring these patients. We have to make sure there are no frontal checks. The nurses don't go and press on the patient's belly. And you have to pay attention to discharge hematocrit. There was a question with Dr. Bateman as to over-transfusing. And, in this situation, you probably want to discharge the patient home at an appropriate trit level, because if they start to bleed at home, at least you have some buffer. I'm not saying that you have to transfuse all these patients to go home, but just pay attention to where they are starting with, and or where they're going home with more so. And again, pain control, extremely important. Post-op pain control, extremely important, not only for early mobilization, but also for your respiratory efforts. And, you could choose to do an uraxial morphine or IV PCA. You can add truncal blocks like a QL block or a TAB block. And don't forget, Dr. Leffert said, don't forget your NSAIDs and acetaminophen for these patients. And, you could do gabapentin as well. To control post-op is very important. Our patients, please, they have vertical skin incisions. They have prolonged refractor times. So it's very important that you maximize your pain control. And what we did before Dr. Turan developed this technique, we used to do all these cases in the main operating room. All the patients had central venous access. In fact, we had 6 units of all products in the room. All patients got IBPCA. There was a high admission to the ICU. The mean blood loss was like 3,500 ml. And in fact, more than 50% of the patients received more than 6 units. But now what do? We do a regular antenatal consult, all the procedures done in L&D OR. And in fact, we include all these patients in the Iraq protocol. I call it Enhanced Recovery After Cesarean Hysterectomy protocol. All patients have an 18-gauge 16 and a 16 or a 14. All patients have A-line. We are doing almost more than 95% of our cases under CSE. They go on lithotomy, and we do have an underbrotic trait that is to suction, duromorph and truncal blocks. And also the CBL, or accumulated blood loss, in these patients is about 1,100, and the pack cell transfusion, more than 6 units, has come down drastically to from more than 50% to 4%. And definitely there are always some outliers. The outliers always make you humble and learn from that, and they help you with your practice improvement. And now, in summary, so multidisciplinary care is very important in these patients. We know time and again, we know that that improves outcomes. Have an open communication with the team members. Do not function in a vacuum. Play with the team, talk with the team. And, it doesn't matter which anesthetic that you choose. And we went over the criteria for the key points for all different anesthetics. And post-operative care is very important in these patients. And lastly, but very importantly, how to start your day or night shift with preparedness. Know whom you have, what gadgets you have, and where the gadgets are to save these patients. And that's what I say is twinning. While we are twinning with the obstetrician, we are yet multiplying as a team. And this is our COS team at the University of Maryland that we work with. And I thank the AOA team and Dr. Kodali and Dr. Turan for all the help.
Thank you, Dr. Shobna and Dr. Turan. As that was a very wonderful, twinning, because we could see one part of the surgery and the other part of anesthesia management. We have so many questions. I don't know from where to start, and we're a little off from the time track. Do you mind being with us and we can address them at the end of the day? I don't want these questions to be left unanswered. Is that okay with you?
Sure.
Yeah, sure.
So we'll move ahead with our next talk, and we will give you all the questions in the chat box so that you can, know what audience is asking. So we move on to Dr. Thomas Drew, and Thomas Drew is a consultant at University College London Hospital. He's an honorary research associate with the Surgical Outcomes Research Group, SOURCE, at University College London Hospital. He did his clinical fellowship at Mount Sinai Hospital, University of Toronto, Canada, and he was involved in establishing the first multidisciplinary combined obstetric and critical care quarterly morbidity and mortality meets at St. George's Hospital. Also, Dr. Drew told me that he is married to an Indian. His wife is from Bangalore. So, welcome, Dr. Drew, to Indian community, and we'll love to hear you speak on refractory uterine atony. Over to you.
Good afternoon or good evening. Thank you for asking me to speak at this meeting. Dr. Balki from Toronto was the original speaker for this slot, and she sends her apologies as she has had to travel for a family emergency. I'm honored to take her place among such a group of esteemed speakers. I am a consultant obstetric anesthesiologist working at University College London Hospital, which is a major tertiary referral centre in the United Kingdom. I was especially keen to take the opportunity to present, as India is a place that's very close to my heart. I got married in Bangalore last year, and I'm very much looking forward to returning to India when the pandemic is over. Over the next 20 minutes, I will briefly discuss the morbidity associated with postpartum hemorrhage, and in particular, atonic postpartum hemorrhage. I will discuss risk factors for refractory uterine atony, as well as pharmacological management using uterotonics. I'm also going to talk to you about the role of tranexamic acid. Uterine atony, or the failure of the uterus to contract after delivery, is responsible for 80% of the cases of primary postpartum hemorrhage. According to the World Health Organization, PPH is responsible for nearly a quarter of all maternal deaths, or about 127,000 deaths annually. Most of these deaths occur within 4 hours of delivery. It's important also to remember that for every one maternal death, there are many, many more that suffer serious morbidity, including peripartum hysterectomy. In India, PPH is the contributory cause for 20% of maternal deaths. There's a lot that we can do in the initial stages to prevent and effectively control PPH. There is excellent evidence that PPH rates are increasing across developed health systems. And it is clear that this is principally driven by a rise in atonic PPH. The blue line here on the top represents PPH from all causes rising from 1994 to 2006 in the United States. The pink line just underneath it mirrors that line, and that is PPH due to uterine atony. But you see on the bottom that PPH from all other causes has remained at approximately the same incidence. What's striking about this data is that it's repeated in many other studies around the world. This one from Ireland again showing a similar increase in the diagnosis of PPH, primarily driven by atonic PPH. The severity of PPH is also increasing, which has led to an increase in interventions, including blood transfusions, over time, despite the fact that in medicine, we're shifting towards a more restrictive transfusion strategy. So why the increase? If we consider the increase in atonic PPH on a macro level, the following reasons have been identified. For example, the rates of cesarean deliveries have more than doubled in India, from 8% of deliveries in 2005 to 17% of deliveries in 2016. There's a global pandemic of obesity. All the time, the maternal age is slowly advancing. There's also been a global rise in multiple pregnancies. And increasingly, there are more women undergoing oxytocin-augmented labor. When we consider individual patient risk factors for uterine atony, essentially uterine atony occurs because of either intrinsic failure of the musculature to contract or extrinsic factors that prevent the uterus from contracting completely. For example, uterine overdistension due to multiple gestation, macrosomia, or obesity. For example, exhaustion or relaxation of uterine muscle due to augmented labor, high poverty, or drugs we give during general anesthesia. Infection is another common cause, as well as functional problems in the uterus, including fibroids and uterine anomalies. Now I would like to talk a little bit about the pharmacological management of PPH. This comprises of first-line agents, oxytocin and its analog carbetocin, as well as second-line agents. And these agents are to be used if our first-line agents fail us. And these, broadly speaking, are ergot alkaloids, carbaprost, or misoprostol. In recent years, we have added tranexamic acid as an extra tool in our armory to defeat and particularly prevent bleeding from PPH. I will begin by discussing the first-line uterotonic agents, oxytocin and carbetocin. And it would be impossible for me to talk about oxytocin and carbetocin without talking about oxytocin desensitization, which is a key concept to consider in the clinical setting. I draw your attention to these laboratory studies, and essentially these are tension measures from strips of human myometrium that's hung in the lab with a pressure transducer that detects contractility of the tissue. And when it detects contractility in the tissue, it records these measurements. And these tissues, these four tissues, groups of tissue, they've been exposed to differing concentrations of oxytocin overnight. And I want you to examine each of these on the right-hand side. And this tissue here has not been exposed to oxytocin overnight. It's been exposed to a control solution. And when it's exposed to oxytocin here again, it has an appropriate increase in contractility dose response. However, as the concentration of oxytocin that the tissue has been previously exposed to increases, you see that the tissue fails to contract appropriately. And that is a critical concept. This concept translates to the clinical setting and is reflected in many studies looking at both dose of uterotonic drug as well as bleeding due to uterine atony. These are studies that have been published over the last 15 years looking at the dose, the ED90 at cesarean section, so the 90% effective dose for most women. What dose will fit 90% of women, the minimal effective dose? And we know that a very low dose is suitable and sufficient for women who have had no prior oxytocin exposure and have a low BMI. However, women with high BMI, even though they may have not have previous oxytocin exposure, they require approximately double the quantity of oxytocin in international units. But in women who have prior exposure to oxytocin in labor, they require a much, much higher dose. Why is this? Well, we need to consider one of the classic papers, and this highlighted column in the middle illustrates the estimated quantity of oxytocin receptors on the uterus, first from a non-pregnant state and then during early pregnancy to later pregnancy, so that by early labor, a woman's uterus has a proliferation, a huge quantity of very sensitive oxytocin receptors and will respond very well to oxytocin. But during advanced labor, as the uterus becomes tired and exposed to more and more endogenous as well as exogenous oxytocin, these number of receptors dwindle. This concept of oxytocin desensitization also translates to the scenario of postpartum hemorrhage, and there are a number of studies which demonstrate that dose, duration, and maximum dose of labor oxytocin augmentation in groups with and without PPH due to uterine atony. So you see that in this case control study, the group of patients with PPH had exposure to far more total dose as well as duration of infusion and maximum dose of oxytocin. Furthermore, this population-based cohort-nested case control study demonstrated that oxytocin during labor appears to be an independent risk factor for severe PPH with a dose-related association. As you can see in this slide, there is huge variability amongst the current society guidelines on how best to prevent and treat PPH, with the following recommendations for prophylaxis at elective cesarean section. It is interesting that despite these very different situations that we have discussed, oxytocin naive and myometrium that's previously been exposed to oxytocin, the Obstetric Society guidelines do not really distinguish between the doses required. And we see doses ranging from 5 to 10, broadly speaking, units of oxytocin. And I'd like you to note as well that the obstetricians in Canada are recommending carbitocin, and we'll discuss that later. So I'd like to draw your attention to a very important international consensus statement published in Anesthesia in 2019. And the reason for this consensus statement was to help anesthesiologists all over the world to focus on the evidence for dosing of uterotonics to prevent PPH at cesarean section. In these guidelines, clear distinctions can be made between women who have been exposed to oxytocin in labor, intrapartum cesarean section, and women who have not previously been exposed to oxytocin in labor, elective cesarean section. And you'll see that the dose recommended at elective cesarean section is 1 international unit of oxytocin initially. However, at intrapartum cesarean section, it's recommended that you start off with 3 international units, and you can repeat boluses if they are not effective. Why focus on using the minimal effective doses? Well, this study tells us why. Thomas et al. Recruited 30 women undergoing elective cesarean section to 2 groups. They were randomly allocated to receive 5 units of oxytocin either as a bolus injection or as an infusion over 5 minutes. And you can see that the boluses of oxytocin, and we see this, of course, in our clinical practice, result in a very significant amount of hypotension. And in certain groups of patients, that can cause significant morbidity, as well as there have been cases, unfortunately, of mortality. There is very little evidence for using 5 international units of oxytocin at cesarean section over smaller doses. The Stanford group, for example, compared groups from 0 to 5 international units in a 75-patient blinded randomized control trial. There was no difference noticed between 0.5 units and 5 units in terms of the uterine tone reported by the obstetrician at cesarean section. However, there was a very significant difference in terms of blood pressure and the incidence of hypotension between the groups. Nearly 50% incidence of hypotension in the oxytocin group. So we've heard a little bit about oxytocin dosing. What about IV or IM dosing after vaginal delivery? This Irish randomized control trial, a double-blind, placebo-controlled randomized control trial published in the BMJ in 2018, compared 2 groups with approximately 500 patients in each group, 500 women in each group. And the primary outcome was PPH greater than 500 mils. There was no difference in the primary outcome, but importantly, in the outcomes of severe PPH, which is blood loss greater than 1,000 mils, and blood transfusion, there was a significant benefit of administering the intravenous form of oxytocin. Carbetocin is a oxytocin analog that has been gaining much more traction as an alternative to oxytocin. It uses the same receptor mechanism on the uterus, and as we know from what I've already said, that this means that it is susceptible to oxytocin desensitization. It has a longer half-life, and that's the primary pharmacokinetic difference. And what that means is that it can be administered as a bolus and doesn't need to be administered as an infusion. I note during my research that carbetocin has recently gained approval for use in India, particularly the heat-stable version. And I know it's probably not available in most of the public hospitals, and neither is it here in the UK because of its cost. But in most of the private sector, I believe that you, as obstetric anesthesiologists in India, will begin to see this drug more and more. There is level 1B evidence for the use of carbetocin over oxytocin at cesarean section. The evidence from randomized control trials are heterogeneous in nature, but more or less positive. I would like to draw your attention to 2 excellent Cochrane reviews on the subject. The first is this 2012 Cochrane review by Su et al., which has led to the Society of Obstetricians and Gynecologists in Canada recommending carbetocin over oxytocin at cesarean section. Gallus et al. Published an enormous meta-analysis in 2019, which compared uterotonic drug combinations for the prevention of PPH, including 137 randomized controlled trials from nearly 90,000 women. And Gallus determined that there was a very significant benefit of adding ergometrin or misoprostol to oxytocin in terms of efficacy, and there was a reduction in the incidence of primary PPH compared to oxytocin with the use of carbetocin. But crucially, ergometrin and oxytocin, as well as misoprostol and oxytocin, were associated with much greater incidence of side effects, which was not seen with carbetocin. This was a randomized control trial published in the New England Journal in 2018. It's a drug company-sponsored study from 10 countries and 23 centers, including India. It's not counted in the Gallus review, and It was a double-blind study where the primary outcome, there were two primary outcomes. One was ppH greater than 500 mils, and the second was ppH greater than 1,000 mils. And they demonstrated non-inferiority of heat-stable carbetocin to oxytocin IM, meaning that there's an enormous benefit to being able to transport and store heat-stable drugs compared to oxytocin, which requires refrigeration. Just to briefly mention doses of oxytocin or of carbetocin, and as you can imagine, they're very similar to what you might expect for oxytocin. Very small doses are required at elective cesarean sections, with higher doses required for women with higher BMIs and in women who have been prior exposed to oxytocin during labor, much higher doses recommended. And I will stress that these are ED90 studies, but the recommended dose at the moment, nearly universally, is 100 micrograms. So to talk about second-line uterotonics, and these drugs are to be used when our first-line uterotonics, oxytocin and carbetocin, are no longer efficacious. And all of these drugs are effective. They're all very poorly studied because it's very difficult to study second-line uterotonic agents. They all have their advantages and disadvantages, and you need to select the right drug based on the patient and the situation that's in front of you. They work via different receptors: ergotamine via alpha and serotonin receptors, carbaprost via prostaglandin receptors, and misoprostol as well via prostaglandin receptors. There are a range of side effects, as I already alluded to, associated with these drugs. This study by Butwick et al. Assessed hemorrhage-related morbidity with second-line agents comparing carbaprost and ergot alkaloids. After accounting for potential confounders, the risk of hemorrhage-related morbidity was higher in the carbaprost group than the metalerdinavine group. Currently, as I said, there are no prospective studies evaluating these drugs as second-line agents, but in the lab, the Toronto group has found that ergot produces superior contractions than carbaprost at equipotent doses. The advantage of ergot over carbaprost is that it can be administered IV, and so it works much quicker. Again, just to remind you of this excellent paper, which gives you a very nice synopsis of the uterotonics at cesarean section and recommends the doses for second-line agents. I would like to mention as well that misoprostol is a very versatile drug and can be administered via a number of routes. It's been a long time coming, but we have another drug to help us manage PPH. This is exciting because it acts via a different mechanism and has produced very positive trial data. Of course, you're all familiar with this drug, but I can't speak about uterotonics without talking about tranexamic acid. This world-famous woman trial for tranexamic acid for PPH was published in The Lancet 3 years ago. The RCT involved 20,000 women with PPH randomized to tranexamic acid.
Of the mother, there could be actually quite a lot of morphine that is present in the breast milk. I see that you nodded that you don't use it, so I won't spend more time talking about it. So yes, to systemic opioids crossing the breast milk. I think it's important in the shared decision-making to tell women, if you're in pain, and you feel you need the opioid, it's fine for you to take it, but you need to be aware that it will cross the breast milk. I've started doing that more and more, and then women say, oh, you know what, my pain is actually not that bad. If I risk harming my baby, I'd rather not take it. I think we've not spent enough time explaining to women what it is that our medication does. As for the alpha-2 agonists given neuraxily, no passage. We haven't really given it systemically, so the question is less relevant for our clinical practice. But to answer the question, the profile between clonidine and dexmedetomidine is that there is a passage, and I think dexmedetomidine is actually more safe than clonidine would be if given systemically.
There's a question on DMI and intrathecal morphine. I think you had highlighted, but maybe you can just, for the delegates' satisfaction, we can review that question again.
So this is a super question. Clinically, there's no study that has evaluated whether obese women are more likely to have respiratory depression than non-obese women with equal doses of neuraxyl opioids. In other words, I know that some of my colleagues in the United States tend to reduce the dose of neuraxyl opioids in morbidly obese patients. We actually don't do that. Our experience over decades now of neuraxyl opioid use is that we don't have respiratory events, and we haven't had a Narcan event in years now. In fact, we continue to redose the opioids if we have an epidural catheter in our morbidly obese patients, but we don't exceed 3 milligram. And we have a tiered monitoring approach for patients. So our morbidly obese patients are admitted to our step-down unit for 12 hours, during which they're monitored. Then they can go to a regular postpartum unit. But if we are redosing the opioids, the nurses know that they're supposed to be monitoring every 2 hours. So I think it all depends with the ability to monitor patients adequately. And if the monitoring is an issue, I would say reduce the dose, but don't omit the neuraxyl opioids in your morbidly obese patients. The alternative of having them get systemic opioids is worse than the likelihood of having respiratory depression with neuraxyl opioids.
The two small questions. One is, what is your experience of local anesthetic infiltration of skin wounds post-cesarean? And the second is the role of regional blocks. Are you using regional blocks? So because regional blocks are an epidemic these days, everybody wants to do TAP and QL. And should it be a routine or should it be just as a rescue block?
Super question as well. So I think that my presentation showed that TAP blocks have zero role when given to every patient if your practice is that you are giving neuraxyl long-acting opioids. In other words, you would be doing an intervention on patients who are most likely not going to see any benefit of it unless you're using long-acting liposomal bupivacaine, because the duration of action of your TAP block or your QLB is going to be shorter than the duration of action of your neuraxyl opioid. So to your question, do we do regional blocks routinely? The answer is no, it's absolutely not routinely done. Do we do it for breakthrough pain or rescue pain in a patient that we're seeing is needing a lot of opioids? It is part of our approach. In other words, this is what we tell the obstetricians and our team, but we very rarely do that because our patients are not breaking through pain with the neuraxyl opioids and the alpha-2 agonists that we give them. I do believe there's a place for for regional blocks if the patient got a general anesthetic. So if a patient got an urgent general anesthetic and there was no neuraxyl approach, we do the block before we wake them up. So as you saw, our general anesthesia rate is less than 2%. So it's not often that we do it, but we would do it on all our patients who did not have neuraxyl opioids.
Well, I think this question must have come because in most of the Indian, community, we do not use morphine very, liberally. And that is one of the reasons why most of the delegates who are attending this session feel it's important to give regional block in their practice. And that is probably this question, why this question came up. Well, the questions are many. If you are there in the gallery, we can, we can reconnect with you and we can finish off the last talk first. Is that okay?
Thank you so much for having me.
Thank you. So we move on to our next speaker. I introduce our next speaker, Dr. Ashraf Habib from Department of Anesthesiology, Duke University, USA. Dr. Ashraf is very well known, and he's in the editorial board of Anesthesia and Analgesia as senior editor, also in the editorial board of IJOA and BJ Education. He has served as a scientific review member in various top level conferences like ASA, SOAP, and SAMBA. Dr. Ashraf was also in the task force panel for Iraq. So he is going to speak today on the same topic, improving outcomes in cesarean delivery. Can Iraq achieve it? So I invite Dr. Ashraf Habib to give his talk on this topic. Welcome, Dr. Ashraf.
Hello, everyone. First, I would like to thank the organizing committee for inviting me to be part of this virtual meeting. And I would like to wish everyone a happy and healthy 2021. Today, I'm going to discuss enhanced recovery after cesarean delivery, or ERAC, something that I'm really passionate about. Enhanced recovery after surgery, or ERAS, is a concept that combines various evidence-based aspects of perioperative care to optimize patient recovery. Initial studies on ERAS were conducted in the colorectal patient population and reported a significant improvement in various aspects of patient recovery, as well as a reduction in the duration of hospital stay. Subsequently, the concept of ERAS has expanded to other surgical specialties, and more recently, there has been interest in adopting ERAS principles to the obstetric patient population. But as we all know, our obstetric patients are very unique and present unique challenges. And therefore, while the general principles of ERAS remain the same, the specific details will vary in women undergoing cesarean delivery. And over the next 25 minutes, I'm going to discuss the various aspects of ERAC protocols, as well as the outcomes associated with their implementation. Here are my disclosures for research support and advisory board work I have done. And here is the outline of my talk. First, I'm going to discuss the quality of recovery indicators following cesarean delivery. Then I'm going to give you a broad overview of the essential elements of an enhanced recovery after cesarean delivery, or an ERAC pathway. Then I'm going to talk into a little bit more details about certain specific elements of the ERAC protocol. And finally, we're going to talk about the impact of ERAC implementation. So let's start by the quality of recovery indicators following cesarean delivery. Recently, a quality of recovery score following cesarean delivery has been published, and it includes 11 items. And identification of those items will help us to know what are the aspects that we need to address in order to optimize patient recovery. So 3 items of this score deal with pain. So in order to address that, we need to implement a multimodal opioid-sparing analgesic strategy. 1 item deals with nausea and vomiting. So we address that by prophylaxis against intraoperative and postoperative nausea and vomiting, and using opioid-sparing strategies to avoid the emetogenic effect of opioids. Next is dizziness, and we address that by prevention of hypotension and by using non-sedating agents for analgesia and for management of side effects. Next item is shivering, and we deal with that by prevention of hypothermia. Next is breastfeeding and holding the baby, and we help with those items by providing early skin-to-skin contact in the operating room, providing adequate post-operative analgesia, and providing breastfeeding support for our parturients. The last 3 items deal with the ability to mobilize independently, to look after personal hygiene, and to feel in control. And we help with those by removing barriers to early mobilization, by removing the IV and the urinary catheter early, by providing adequate post-operative analgesia and adequate control of post-operative nausea and vomiting, and by providing patient education so that our patients know what to expect during their hospital course, and therefore they can feel in control. Next, I'm going to provide you with a broad overview of the essential element of the ERAC pathway. And similar to other enhanced recovery protocols, this is divided into preoperative, intraoperative and postoperative components. So the preoperative components first deal with patient education. We need to let the patients know what to expect during their surgery, what to expect during their hospitalizations. They need to know that we're going to aim to mobilize them early and to feed them early. They need to know what are our pain management strategy that we're going to use. They need to know what to expect in terms of duration of hospital stay and what will be the criteria for discharge from the hospital. The antenatal period is also an opportunity to optimize comorbidities such as diabetes and hypertension, and also to correct anemia. At our institution, we have an anemia clinic, and we have certain criteria for referral or obstetric patients to the anemia clinic in order to optimize their hemoglobin. NPO status should be according to ASA guidelines, 6 to 8 hours for solids and 2 hours for clear liquids. And many ERAS protocols include a preoperative carbohydrate drink 2 hours before surgery. And these carbohydrate drinks have been shown to reduce insulin resistance, reduce preoperative thirst, hunger, and anxiety. Finally, we need to establish ERAS protocols with the patients so that they are involved in the recovery process and motivated in order to move through all the goals that they need to achieve. Now let's talk about the intraoperative components. So the main anesthetic or the anesthetic of choice is a neuraxial anesthetic with long-acting neuraxial opioids. We need to prevent infection by administration of appropriate antibiotics and providing skin and vaginal preparation. We need to prevent hypothermia by active warming, prevent hypotension, provide prophylaxis against intraoperative and postoperative nausea and vomiting, and final two items are delayed cord cramping and early skin-to-skin contact. Postoperatively, the mainstay for postoperative recovery is the provision of adequate multimodal opioid-sparing analgesia. We need to aim for early oral intake and early mobilization and remove barriers to early mobilization, including IVs and urinary catheters. At our institution, we remove the urinary catheter 6 hours after surgery. We need to provide thromboprophylaxis according to guidelines, provide our patients with lactation support, and coordinate with the neonatal team so that patient's discharge is not delayed because of issues relating to breastfeeding or relating to the baby. And finally, you need to continuously audit compliance with the various elements of the protocol, as well as audit your outcomes in order to continuously be able to fine-tune your protocol and monitor and improve your outcomes. Now let's talk into a little bit more details about some elements of this protocol. And we're going to talk about hypotension, hypothermia, nausea and vomiting prophylaxis, and multimodal analgesia. So let's start with hypotension. And we now have very good evidence to show that fluid loading strategies have limited efficacy in the prevention of hypotension. Whether you give fluids by a preload or a co-load, or whether you give crystalloids or colloids, at best, you reduce the incidence of hypotension from 70 to 80% to about 60%. So the mainstay for the management of hypotension is the use of vasopressors. And this is not surprising because the main pathophysiology of hypotension is vasodilatation rather than hypovolemia. And now we have very good evidence to show that phenylephrine is the vasopressor of choice in obstetric patients. When compared to ephedrine, phenylephrine is associated with improved neonatal acid-base status, as well as improved maternal comfort. There is less intraoperative nausea and vomiting when you use phenylephrine compared to when you use ephedrine. So what is the optimum method of phenylephrine administration? The optimum method is by giving it through a prophylactic infusion. This is one of many studies that compare the administration of phenylephrine by prophylactic infusion versus administration through a bolus for the treatment of established hypotension. And when you give it as a prophylactic infusion, there is less hypotension and there is less intraoperative nausea. In our practice, we initiate the phenylephrine infusion at 50 mics per minute, and then we change the infusion rate if needed based on the blood pressure response. So what should be your target blood pressures to maintain? This was an elegant study that used the phenylephrine infusion and aimed for 3 goals for blood pressure control. One group had the blood pressure maintained at 80% of baseline, the other group at 90%, and the third group at 100% of baseline. And as you can see here, the tighter control the blood pressure, the less the incidence of intraoperative nausea and vomiting. Nausea and vomiting occurred in 40% of patients when the goal was 80% of baseline, 16% when the goal was 90%, and in only 4% when the goal was 100% of baseline. In the last few years, there have been interest in using phenylephrine as a vasopressor, norepinephrine as a vasopressor. And there are a number of studies that compared norepinephrine to phenylephrine. This is one of the best studies that have been published. As you can see here, there was no difference between norepinephrine and phenylephrine as far as systolic blood pressure control, but because norepinephrine has a beta agonistic effect, heart rate was higher with norepinephrine compared to phenylephrine. And because of the higher heart rate, the cardiac output was higher with norepinephrine compared to phenylephrine. Stroke volume is the same, but the SVR is lower with norepinephrine compared to phenylephrine. So the higher cardiac output and the lower SVR could theoretically lead to improved peripheral perfusion. It could theoretically lead to improved placental perfusion, and studies are needed to investigate whether the use of norepinephrine can provide a benefit in certain high-risk pregnancies. But for now, there is no convincing evidence that it provides improved outcomes compared to phenylephrine, and phenylephrine remains the vasopressor of choice at the time being. Next, for management of hypotension, we need to give appropriate doses of uterotonics. And historically, we have been giving large doses of oxytocin, much more than what we need. And oxytocin is our first line agent uterotonic. This was a study that looked at the ED90 of oxytocin infusion in non-laboring patient as well as in laboring patient. So those who are non-laboring, who were not exposed to oxytocin before, the ED90 is 16 international unit per hour. And for laboring patients, it's more than double that value. It's 44 international unit per hour. The same applies if you give oxytocin as a bolus. The ED90 of oxytocin bolus for elective cesarean delivery is 0.35, and for intrapartum cesarean delivery is about 3 international units. So again, much less than what traditionally has been given, which was 5 to 10 units of oxytocin. This is a recent study that looked at the ED90 oxytocin bolus in obese patients and found that it's actually almost double the ED90 in non-obese patients. I'm not sure about the practice in India, but in our practice here in the US, we are seeing a lot of patients who are obese. So this is an important study to remember. Last year, a international consensus statement about the use of uterotonics was published, and they recommend for elective cesarean delivery giving 1 unit of oxytocin bolus followed by an infusion of 2.5 to 7.5 units per hour. And if we don't have adequate uterine tone, after 2 minutes, you give a further 3 units. For intrapartum cesarean delivery, they recommend giving 3 units to start with, followed by an infusion of 2.5 to 7.5 units per hour. Next, I'm going to talk about the prevention of hypothermia. And the impact of hypothermia has been very well characterized in the general surgical population. We have now very good data to show that hypothermia leads to increased blood loss, increased risk of complications, including wound infection and myocardial ischemia. It affects the pharmacokinetics of drugs and leads to prolonged duration of stay in the recovery room and prolonged hospital stay, therefore leads to increased cost. However, hypothermia has not attracted a lot of attention in the obstetric patient, despite that the fact that occurs very commonly in women undergoing cesarean delivery under spinal anesthesia. This was a study that showed that when no active warming is instituted, hypothermia occurs in 91% of patients. Even when active warming was instituted, the incidence of hypothermia was 64% in this study. So a significant number of patients become hypothermic. And it's not only the magnitude of hypothermia that's underappreciated, but it's also the duration of temperature drop is also very much underappreciated. This was a very elegant study from a group from South Africa, where they had the patient ingest a temperature sensor, and they managed to characterize the hypothermic impact that occurs following spinal anesthesia in a patient population where active warming was not routinely used. So here you can see that the temperature dropped by a mean of 1.3 degrees, and the median time to the lowest temperature was 1 hour after the spinal anesthetic was given. In 75% of patients, the temperature continued to drop after leaving the operating room, and in 29% of patients, the temperature did not return to baseline at the end of the 8 hours of the study, and it took a median of about 4.5 hours for the temperature to return to baseline. So what can we do about hypothermia? Active warming has been shown to be useful in reducing the risk of hypothermia. In this meta-analysis, you can see about a 34% reduction in the risk of hypothermia with active warming, a 42% reduction in the risk of shivering. The temperature at the end of surgery is higher with active warming. The patients have greater thermal comfort, and umbilical artery pH is even higher when active warming is instituted. And not only active warming could be used, but also you have to pay attention to the ambient temperature in the operating room. This was a study that compared two ambient temperatures, 20 degrees versus 23 degrees, and found that with the higher temperature, the incidence of neonatal and maternal hypothermia was significantly lower compared to the lower temperature of 20 degrees centigrade. Next, I'm going to talk about nausea and vomiting prophylaxis. I'm going to start with intraoperative nausea and vomiting. And there are anesthetic factors and there are surgical factors that contribute to intraoperative nausea and vomiting. So first, anesthetic factors. Prevention of hypotension with using a variable rate phenylephrine infusion is very effective in reducing the risk of hypotension, as we already discussed. Improving the quality of the block by adding a lipophilic opioid to your local anesthetic reduces the incidence or the risk of intraoperative nausea and vomiting. This was a recently published meta-analysis that showed a 59% reduction in the risk of intraoperative nausea and vomiting when you add intrathecal fentanyl. Intrathecal fentanyl improves the quality of the block, reduces intraoperative pain and the need for any intraoperative opioid. All of these could lead to intraoperative nausea and vomiting. Giving prophylactic antiemetics, combination of antiemetics. A few years ago, we did the study where we used metoclopramide and ondansetron in patients who were receiving a phenylephrine infusion and found more than halving on the incidence of intraoperative nausea and vomiting with this combination in patients who are receiving phenylephrine infusion. Next, we'll talk about surgical factors, including externalization of uterus and irrigation, saline irrigation at the end of the section. So externalization of the uterus more than doubles the risk of intraoperative nausea and vomiting. It also increases the risk of intraoperative pain and should largely be discouraged. Intra-abdominal irrigation at the end of the section has also been shown to increase the risk of intraoperative nausea and vomiting, as well as the risk of postoperative nausea and the need for rescue antiemetics, without any beneficial effect in terms of reducing the risk of infection, postoperative fever, or postoperative endometritis. For postoperative nausea and vomiting, you need to use a combination antiemetic therapy. So in our practice, we use dexamethasone in addition to metoclopramide and ondansetron, as I already mentioned, that help with intraoperative nausea and vomiting as well. The details of the postoperative analgesic regimen will largely impact postoperative nausea and vomiting. So attention to the dose of intrathecal morphine and using opioid-sparing techniques are essential to reducing the risk of postoperative nausea and vomiting. So now we'll talk about multinodal analgesia. And I know you just heard a lecture from Dr. Landau about postoperative analgesia, so I'm not going to spend a lot of time on it. I'm just going to give you a few highlights. So first, we need to pay attention to the dose of neuraxial morphine. We know that with neuraxial morphine, there is an analgesic ceiling and dose-related increase in side effects, meaning that there's a certain dose above which you don't get any further improvement of analgesia, but you only get an increase in side effects like pruritus and nausea and vomiting. So for neuraxial morphine intrathecally, 100 to 150 micrograms is the dose to be used. For epidurally, 3 milligrams. Next, we need to use systemic adjuncts, and we need to give non-steroidals and acetaminophen on a scheduled basis, round the clock. We need to give them concurrently rather than on alternating basis, and we need to initiate their administration preoperatively or intraoperatively rather than postoperatively. Other strategies such as gabapentin, ketamine, uraxial clonidine, truncal blocks, local anesthetic wound infusion could be very helpful in certain select patient population, including patients with chronic pain or patients who are expected to have high levels of pain after surgery, but their use for all patients had not been shown to be beneficial, and for some of these modalities such as gabapentin and ketamine, they can be associated with side effects. Finally, truncal blocks with a long-acting preparation of bupivacaine, such as liposomal bupivacaine, have recently been shown to be useful in patients receiving neuraxial morphine and regular NSAIDs and acetaminophen. However, this modality is expensive, so we need to consider the cost effectiveness ratio of this intervention before widespread implementation. Finally, in the remaining couple of minutes, I'm going to talk about the impact of IRAC implementation. And I'm going to show you first a study from a large integrated health system in California that implemented IRAC, and they showed that with IRAC implementation, including all the preoperative, intraoperative, and postoperative components that we talked about, they achieved early ambulation, early feeding. They implemented a multimodal opioid-sparing strategy, and they significantly reduced postoperative opioid consumption. This is a meta-analysis that our group performed. This data is not published yet, but I can share with you some of the results here. We can see as far as the process metrics, time of urinary catheter was reduced by almost 12 hours with IRAC protocols. Time to mobilization occurred almost 8 hours earlier with an IRAC protocol. Opioid consumption was significantly reduced with IRAC protocol, and the duration of hospital stay was reduced by an average of half a day with IRAC protocols implementation. So overall, significant improvement in outcomes and significant improvement in analgesia and opioid sparing. So in summary, IRAC is a protocol that really follows the best evidence for various aspects of preoperative, intraoperative, and postoperative care. It requires multidisciplinary collaboration, and it is a protocol that you have to develop for your own institution according to the resources that you have in your own institution. You can adapt the protocol and implement the elements that work within your practice. And recently, the Society of Obstetric Anesthesia of Perinatology and Perinatology, or SOAP, published their consensus statement and recommendation for enhanced recovery after cesarean delivery, and I highly recommend that you read this document. Thank you so much for your attention, and I'll be happy to take any questions.
Thank you very much, Dr. Ashraf. And we have successfully completed all the lectures of today. And there are a couple of questions for you. One of the delegates has asked, this has been a very frequently asked question in other forums also. What is the role of chewing gum to increase bowel movements?
So there is, thank you for this question. There have been some literature, mainly in non-obstetric patients, showing potentially some beneficial effect of chewing gum for accelerating the time to return for bowel function. So I'm not aware of any studies in obstetric literature, but in non-obstetric literature, yes, there are a number of studies showing that it can potentially have some beneficial effect in accelerating return of bowel function. But these are mainly studies in patients who undergoing general anesthesia.
Okay. So, well, another question is like, are there any barriers to implementation of Iraq bundles in your setup? Like,
so, of course, when you look at Iraq protocols in general, it varies from institution to institution what your practice was prior to looking at adopting an Iraq bundle. So, for instance, when we look at our own practice at Duke, the main change that we had to do was related to patient education, formalizing patient education material. The rest of the elements were largely part of our practice. So the largest change really was related to patient education and preoperatively and establishing goals in conjunction with the patients to motivate them for the recovery process. But of course, it's a multidisciplinary approach. You have to involve the obstetrician, you have to involve the nursing staff in order to be able to implement all these elements across all the phases of care.
Thank you very much. And what would your take be for the developing countries who have issues in discharging these patients second or third day post-surgery vis-a-vis Western world where the discharges are as such happening early? So how would you like to, counsel us, or how would you like to, suggest us to implement Iraq bundles in this scenario?
So this is a great question, and something that comes up frequently regarding early discharge from the hospital. And actually, the question of discharge from the hospital is largely dependent on where people are practicing. So, for instance, if you compare, for instance, in the US versus the UK, the UK has largely been able to achieve first day discharges following cesarean deliveries. Whereas in the US, in many states, there's certain requirement for the patients to remain in the hospital for a certain number of days. So I don't think that the duration of hospital stay should be the emphasis of Iraq protocols. I think the emphasis is optimizing all the other aspects of patient care. And if it's possible to achieve earlier discharge because the patient has fulfilled all the discharge criteria, if you have, adequate follow-up for the patients after discharge, I think one of the big differences, for instance, between the US and the UK is that in the UK, they have midwife follow-up for the patients at home, which facilitates the follow-up and ensuring that the patients are doing well, where this is not really happening in the US. So it's really country dependent and practice dependent. And the duration of hospital stay should not be the main emphasis or the main outcome of IRAC protocols.
Well, I'm not able to understand the question completely, but it says, what is the role of extraperitoneal approach by obstetrician to do LSCS for IRAS?
Is this question relating to
I feel it must be exteriorization of uterus? No. Extraperitoneal approach by OB to do LSCS by IRAS. I think we'll ask the delegate once again because it's not very clear. Okay, another question is like considering developing countries and the social customs, somebody has asked this question also, in which women are not allowed to leave the house for 1 month post delivery. Would the Iraq protocol be, violated in such cases, or we are only limited till discharge from the hospital, or we want the women to be up and about when she goes home too?
We definitely want the women to be up and about in the hospital and when she goes home. We know that our obstetric patients are at a higher risk of thromboembolic complications. So we need them to mobilize early, both during hospitalization and after discharge from the hospital. And this is really the role of patient education and the role of adapting the patient education to your local practice. So the information I'm giving to my patients at my institution here at Duke would be very different from another institution in the US, which would be very different from another institution in India, because the general principles are known, but you adapt these principles according to your local practice. So, and you adapt your education according to your local practice and your local custom.
Okay, the question says that without opening the peritoneum, if you are doing LSCS.
I'm not sure I understand the question, whether it relates to closing the peritoneum during the repair there are the obstetrician practices. There are some obstetricians who close the peritoneum, others who don't. And there are data to show that there are really no clear benefit from closing the peritoneum. So in our institution, we don't. Our surgeons do not close the peritoneum. But I know there are surgeons' differences in terms of their practice, whether they close the peritoneum or not. But there are several data to show that closing peritoneum really doesn't confer any additional benefit and just prolongs the duration of the surgery. I hope this is the answer to that question.
Well, if there's anything, we'll get back to you. We can be still online because we have some questions lined up for Dr. Arvind, Dr. Zen, Dr. Turan and Shobna and Dr. Thomas Drew. If you don't mind, we can all come on the panel and we can just take the questions one by one and everybody can, take the questions. So I'll request the web to have everybody in the gallery view and we can, So, So I can ask Dr. Arvind first. There are some questions for you, Arvind. There is Arvind.
Absolutely, yep.
Yeah.
I'm listening.
Yeah. Arvind, I sent you the questions. So we'll start with some people are asking if you have to give oxygen support to women who are pregnant, can we use non-invasive ventilation?
Absolutely. I think nothing changes. I think at our institution, they are just treated like every other critically ill person. If non-invasive ventilation is required, they're not denied that opportunity. The one thing I don't have experience with is prone positioning, but I know that there have been a couple of reports suggesting the feasibility of prone ventilation in pregnant subjects.
Is the risk of bleeding more in COVID-19 patients undergoing C-section?
Not that I'm aware of. I'm not aware of any literature. And in fact, the opposite might possibly be a problem, which is immunothrombosis and the possibility of VTE. Again, the evidence for that is weak as well. So I don't think there's good data to suggest that there's excessive bleeding in patients with COVID-19.
And there's another question which asks whether there is any correlation between the pathophysiology of preeclampsia and COVID, considering both, are concerned with endothelial damage. And does COVID worsen PIH and vice versa?
I think that's a great question. I can answer the first component. Certainly, at least in my institution, a vast majority of patients with critical COVID-19 have always had either chronic hypertension or a diagnosis of preeclampsia. And those are the patients who ended up being more sick than the other non-hypertensive cohort. So there's, at least anecdotally, I see some kind of association, but I'm, again, not aware of good quality literature that has teased this data apart to tell with clarity whether that's true. But if you look at ACE2 expression, all the angiogenic factors, it makes sense that COVID-19 would probably be more of a problem with preeclamptic patients. Regarding the second question, I have absolutely no idea whether it worsens preeclampsia or whether preeclampsia has another modifying influence on COVID-19. That's, again, I've not come across good data to make any recommendation.
I think we can ask Dr. Ruth to also pitch in any answer because she has also good experience. And anybody among you who has also worked in COVID, all of us have done actually. So maybe Dr. Ruth can put in some words too.
Thank you. So interestingly, our patients have not been that sick. It's interesting. We have been giving oxygen. We have been giving even CPAP. We have been putting them in negative pressure rooms to reduce the likelihood of having healthcare providers contamination and exposure. We have not had to manage patients in the prone position, and so I have zero experience with that. Of all our sick patients, we only had one or two who actually required intubation, and we were quite happy to see that our outcomes were positive. I think that others here on the call, Dr. Leffert, Dr. Habib as well, have actually managed quite sick patients.
So anybody else would like to add on to this? So there's another question also. Someone has asked, is the risk of bleeding more in COVID-19 women? And if so, can we give tranexamic acid to these women if they're posted for a scheduled LSCS and they're bleeding profusely on table? Dr. Lisa.
We're knocking our heads here. Obviously, it's a trade-off. The risk-benefit. You don't want a patient to be exsanguinating and lose, an excessive amount of blood. On the other hand, we know that COVID is associated with an increased coagulation profile. So giving TXA carries a risk. Obviously, there's been no study. There is very limited evidence to support the use or not of tranexamic acid. I think it has to be a case-by-case decision on looking at whether other interventions are actually decreasing the blood loss and improving the coagulation cascade. I believe we have not used it, but again, we haven't found the need to do it. And I think this is a perfect question to be addressed in large series, and I don't think we'll ever be able to do randomized controlled trial to assess that, but maybe people's experience will inform our decisions in the future.
I think it's really important not to extend that worry to neuraxial anesthesia and patients with COVID. So the vast majority of patients with COVID can safely get neuraxial anesthesia, and that's important to remember.
One thing that we've been trying to do is bedside thromboelastograms. And that has been somewhat helpful in sort of organizing our thoughts of where patients are. But it's a difficult and evolving situation, and even TEG takes some time before we get information.
Well, Dr. Zain, there is another question for you. Do TOLAC patients need any special changes in monitoring or drug concentrations and precautions during labor analgesia?
Yeah, I think any standard sort of considerations apply to TOLAC patients, and it mostly has to do with having adequate personnel available just in case you need to do a stat cesarean delivery. So even if you have a Noraxil, a DPE, a conventional epidural, or a combined spinal epidural, you need to have personnel readily available to do the stat cesarean delivery. One thing that we have found is even after a DPE where a stat cesarean delivery has been called is we've been fortunate that we have not seen abnormally high blocks resulting from those types of techniques. And so we feel very comfortable in just doing what we normally do. We dose very carefully. We aspirate between small doses, and we watch for clinical effects.
So there's another one. What is your opinion on reversal of motor block using epidural saline?
Yeah, that's a question that we actually looked at some time ago. And there does seem to be some value in giving epidural saline to wash out, if you will, an epidural space. We found the effect to be very modest, and you must use preservative-free saline. We have considered studying it more aggressively, but it's been kind of low priority on our docket. But it's an interesting process.
So then there's another one which says, does the level of puncture on skin and depth of catheter insertion affect the epidural dose?
Does it depth? This probably relates in part to, is someone high BMI and or a large individual? And in terms of what response people have to both combined spinal epidurals, dural puncture epidurals, and conventional epidurals, there is some data to suggest that high BMI individuals need slightly less amounts of medication in their epidural space, thinking that there is increased intraepidural pressure, and therefore any injectate into that pressurized zone is spread farther. But more data needs to be collected in this regard.
So there's one more question, if you can take it. Your experience in COVID patients needing labor analgesia.
Yeah, and this is good for the entire group. Arvind?
Yes, everybody can.
Kajal, do you mind repeating the question?
Yeah, the question is, what is your experience in COVID-19 patients needing labor analgesia?
Well, we've been doing exactly what we have done before, offering labor analgesia services to pretty much every patient with COVID-19. In fact, we've been more aggressive with offering labor analgesia, primarily to prevent the possibility of having to administer an unplanned general anesthetic. So in fact, we've been, placing preemptive epidurals in some patients, even when they're not in labor, to avoid those circumstances. So that's been my experience. Nothing has changed. And in fact, the risk versus benefit, even in the setting of low platelet counts that can occasionally be there, would firmly be skewed towards neuraxial analgesia.
There's another one coming up on COVID. I think Dr. Ruth can take it. Are you giving NSAIDs to COVID patients? There was a discussion in the beginning of the pandemic to avoid it.
That's a super question. There was there were some suggestions coming from the French community that NSAIDs given to patients who were having who were infected could actually exacerbate the severity of the disease. However, this has not been confirmed, and the French government retracted this recommendation. In our early approach, we said that in the absence of strong evidence, consider omitting the NSAID, but very rapidly, the SOAP in particular, the interim recommendations actually reassured the OB anesthesia community that omitting the NSAIDs would actually contribute to what we're trying to avoid, which is reliance on opioids. And therefore, the recommendations were pretty straightforward that NSAIDs should and could be given to patients with COVID disease. So yes, absolutely, it's not a contraindication. There's absolutely no evidence that it increased the severity or worsened the severity of the disease or had any impact on the course of on the prognosis of the conditions.
Thank you very much. And there are few questions for Dr. Turan and Dr. Shobna. The first one, which is which has been asked by many people, is the rationale of performing a hysterectomy prior to handheld vessel ligating technique. What is the rationale of performing a hysterectomy prior to handheld vessel ligating technique? Why should you do it?
So do you mean that the opening hysterectomy using linear cataract?
Yes.
Okay. The reason for is hysterectomy, when you do an incision, it bleeds. Is about, according to approximately the study, is about 400 to 500 cc bleeds from just only hysterectomy site. And if you even put a whip stitch to close the uterus, that bleeding is continuous. It doesn't really stop. And if you think that the hysterectomy takes about an hour or 1.5 hours, that bleeding continues as always. And you add your blood loss, increase your blood loss. That's the reason I use linear cutter to cut the uterus. Then that edges doesn't bleed during my hysterectomy time. And it's actually more beneficial for us to control blood loss. Sorry, hospital is calling me.
We can take the call a little later.
No, don't worry. I will come back then. I just want to tell one more comment about the previous question about the extraperitoneal C-section. As a surgeon, I think I can answer best that question. The question was extraperitoneal C-section, which is a very old technique used in 1960s, 1950s, when we do not have enough antibiotic coverage. Means that you don't go into the abdominal cavity, you just elevate the peritoneum and reach the uterus and do the C-section. I don't remember when I did last time, because after the antibiotic era, we don't really concern about this infection. I don't have any experience to answer the question of if Iraq works better in those cohorts or not, but logically, yes, because you're not in the belly.
So the other question was, if you're using that linear stapler, can you tell us what is the cost of that stapler? And would it be good enough to go with only ligating bit by bit rather than, doing using this linear stapler, especially for a developing nation like ours?
Good question, excellent question. So, as everyone knows that your technique, your approach is delineated by your culture or environment. In the United States, that is not too expensive. It's not more than $100, but it could be $100 is a big money for other nations. In olden days, what I was using, doing a small incision using clamps, and ligating one by one, it takes some time. But if you leave open the hysterectomy or just try to close immediately, definitely you increase your blood loss. In the United States, it's not too expensive, and it is doable very easily.
Sorry, sir. Then there's one very challenging question someone has asked, and that is, if you are faced with the situation where you have to do a perimortem C-section on an obese parturient with placenta creta, what would be your take?
If I don't misunderstand, the mother is already dead, correct?
Yes,
it's
yes.
Mortem. Yeah,
like resuscitative hysterectomy.
Yeah, I mean that's we don't need to restrict them and just take the baby out, try to save the baby, and close the uterus. I guess that's the best option.
And well, for Dr. Shobna, there were a couple of questions. Like I think she already answered in her slides. There were questions on what should be the minimum blood we should reserve for a patient with placenta creta. So you had already, I think, written, but you can still tell them for the sake of revision.
Sure. Like again, it depends on what your average blood loss is. Like I said, in our practice, before Dr. Turan introduced this LCVSS technique, we used to have 6, 6, and 1, for packed cells, FFP, and platelets in the room. Because at that time, our average blood loss was 3,500. But now we just have 4 units of packed cells in the operating room. And regardless of the placental invasion, we have 4 units these days, be it in a creta or be it a creta.
There's another question. How do you prevent hypothermia in a patient who has massively bled? Like, do you use under-patient drapes, or is it only the warming systems you're using? Or you're using something else too? Because, hypothermia is going to worsen the outcome of the patient.
That is correct. So we have to start warming the patients from the get-go. Especially in these planned cases, as soon as you lay the patient down, get started, we use a forced air warmer. And then we also have a warming mattress. So we have 2 of that plus the fluid warmer. So we have like about 3 devices to help warm the patient. And it definitely is a challenge because our patients are on lithotomy and all the surface area that we are exposed is, just the upper chest and the arms. So it is a challenge, but if you get started, ahead in the game, it would help.
What is the role of interventional radiology in patient of placenta creta spectrum? Should it be routine or only in very high-risk patients?
I'm going to defer that question to Dr. Turan, actually. The data.
So we don't use aortic balloon or any kind of balloon placement because a occlusion of blood vessels is actually increase your blood loss before the complete dissection of the bladder. That is the key point of my technique, our surgical technique. Therefore, I don't use. In some cases, I leave the placenta in because of the extension of the placenta to the parametrium or into the bladder. And to avoid significant blood loss, I didn't go that detail in my presentation because it's the limited time. I leave the placenta in. At those cases, sometimes I go and embolize the uterine arteries to go back in 4 to 6 weeks later to do definitive surgery, but I don't use routinely.
And there's one question, this is from an obstetric colleague. Are there any tips and tricks to identify the adherent bladder during the surgery?
Oh, I mean, it is very easy to identify that is adherent. If you don't see any plane, that's the reason is not for the placenta actually, because of the multiple surgeries. As we know very well, all those cases has more than 2 or 3 C-sections. Rarely it can happen in 1 C-section, but most of them has 3, 4, 5 C-sections, and that adhesions creates a huge impact on your dissection. When you hold the bladder and it's just on the placenta, is not moving, that's pretty clear. It's going to be difficult to dissect.
I think that's a very challenging question. There are many more, but I'll stop at that. There is one for Dr. Thomas Drew. How to prevent nausea, vomiting following carboprost administration?
Thank you for the question. I'm not sure that has been studied in particular. So I think that the sensible option would be to use the drugs that we already have and that we know are effective at cesarean section, particularly ondansetron. I know there's increasingly more evidence for the use of dexamethasone at cesarean section, particularly for post-operative analgesia, as well as any other antiemetics that we have available. But as I did mention, of course, these side effects are serious. They're serious for our patients, and they are what stop our patients leaving hospital on time. And I think that's increasingly important, particularly in this world of RAS that has been discussed so well through the seminar.
Thank you, Dr. Drew. Thank you very much. And I think we can close the session. It has been a very, very engrossing evening. And we look
Actually,
forward to
Dr. Kajal Jain, this is Shovana. I just wanted to add for the initial question or comment about the prone position. There was a great talk, Dr. Palnisamy. We just wanted to add our experience with the prone position for the COVID patients. We do have quite a number of sick patients in our hospital. In fact, we have one who is on ECMO and a trach and all that. So we do prone positioning in the ICU. We have like certain devices where that would accommodate the pregnant abdomen. And also we have done 12-hour trials. We are trying to look into the data about how much has that, changed the patient's course. We have awake patients who are on oxygen requirement in our labor and delivery unit who self-prone. So we are actually starting to look at the data on those patients who do undergo the proning. But our ICU, the lung rescue unit, where we have these patients, or the medical ICU is where we have these patients, and we've been doing some prone positioning. It takes a lot of team effort. It takes a lot of team effort, but it has been doable in our setup.
So that's a very good update on patient management who are very, very sick and require proning, and then ECMO for ECMO also. Thank you very much. And again, I would like to thank all the speakers on behalf of the National Association of Obstetric Anesthesiologists, who have come forward to deliver important information on pregnant women and for safer life births. I extend a very, very hearty thanks from all of us, and I expect that we all will be together even tomorrow morning. If you can be with us, that will be really good. And to give a concluding note to this event, I would like you to please rise up for the national anthem of my country. And if you can, please, we'll just rise up and we'll sign off for today.
अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मागे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
Thank you. Thank you very much. We'll see you tomorrow. Thank you.